Good morning, everybody. We are now on to our plenary session. Some rules on the plenary session. Each speaker will be given 5 minutes to present. Please make sure you keep to your time. And then question is for 2 minutes. We will call on the first candidate, Dr. Dhanush Thomas. Please come and make your presentation.
I'll start, sir. Yeah. Good morning. Today my topic is incidence and risk factors of hepatocellular carcinoma in patients of hepatitis C following treatment with directly acting antivirals, a study from a tertiary care center in Tamil Nadu. Now, coming to the introduction, that hepatitis C is a infection which can affect almost 150 million individuals, and when cirrhosis is present, the incidence of HCC is around 3 to 7%, and with the introduction of directly acting antivirals, the SVR rate achieved is very high, and once SVR is achieved, usually the risk of HCC starts coming down. Initially, there were studies saying that there was high risk after HCC, but the following studies, the follow-up studies showed that there is no actual risk. So our aims and objective is to assess the incidence of HCC in HCV cirrhotic peoples who achieved SVR post-DAA, and the secondary objective being to study the various risk factors in HCV cirrhosis who have achieved SVR and who is diagnosed with hepatocellular carcinoma. Now, the materials and methods they have taken is it's a retrospective study. All patients from January 2018 to December 2022 from the OP and IP records were taken, and the inclusion and exclusion criteria we did was a chronic HCV patient with cirrhosis, age more than 18, and they should be treated with a standard treatment with DA, preferably IFN-free regimen, and should achieve SVR after treatment, and the exclusion criteria being non-cirrhotics and those who have not achieved SVR after SVR 12 after treatment with DA and who has had HCC prior to DA treatment. And statistical analysis was done with SPSS software, where the continuous variables, all the variables were calculated. And after calculation of variables, the area under the curve and ROC analysis was done to apply the cutoff for which classifying patients with HCC. And regression analysis was performed to investigate the association of each variables. Now, the baseline characters what we had around 176 patients with chronic hepatitis C retrospectively taken, and 61% had cirrhosis or advanced fibrosis. These patient characters like age, sex, platelet count, liver function test, imaging, AFP levels, and ALB score was taken, and all were treated with IFN-free regimens, and HCV viral load was checked at 4 weeks, 12 weeks, and 24 weeks, and HCC screening was done at 6 monthly intervals. And all patients are screened for hepatitis B and vaccinated for hepatitis B. There was co-infection with hepatitis B for 3 people, but we have taken them out of the study, and ALB score was taken. This is the formula, 0.85 into albumin and 0.66 into total bilirubin, and they were graded into 3. That is, higher the ALB score, poorer the this one. And genotyping was done. And based on that, the baseline characters were age was around 57, and predominantly males, genotype 3 being common, and platelet count at starting was 117, and bilirubin, AST, and albumin was 1.2, 54, and 3.6, and median follow-up period was just 42.4 months. Now, other comorbidities which are seen in these people are diabetes was found in 37 people, hypertension in 23, BMI more than 23 is seen in 67 patients, associated NFLD was also seen in 18 patients, significant alcohol consumption was seen in 18%, and USG imaging was done in start of treatment as normal. There was no evidence of any mass. Now, in the patients who developed HCC, the incidence was follow-up period for was 18 patients, that is around 17%. That was incidence of around 3.2 per 100 patient years. And the mean age of diagnosis was 62 plus or minus 8 years. Males were more affected. And post-DAA, the average time to develop, our study shows 18.42 to plus or minus 5 months, with genotype 3 being the most common. And radiologically, most lesions were small. And only 2 patients had multicentric HCC, and 3 patients had even recurrence of following days. Now, analyzing these 18 cases had a mean age group of 62, with males predominant and genotype 3 most common. Platelet count was 92,000, bilirubin was 1.7, mean albumin was 3.4, and ALB score was 1.87. Post-DA AFP levels was 4 plus or minus 0.8, and significant alcohol consumption was seen only in these patients. These are the 18 cases, those who have become positive for HCC we analyzed. Now, based on the Cox regression analysis, we had seen whether this is significant or not. Now, the age more than 59, albumin less than 3.6, and follow-up platelet less than 90,000, and follow-up albumin, diabetes, alcohol consumption, ALB score almost showed a significant value. There is significant association between these. Now, based on the study, the high risk was being advanced age, increased child status, mean pre-treatment platelet was less than 1 lakh, and AST more than 48 and higher ALB score.
What is this? Can you summarize? What's the
Yes, sir. So, the recommendation what we'd like to place is,
conclusion of the risk factors?
conclusion of risk factors is basically those who are at high risk of developing HCC, where patients who are with higher age and increasing child status with mean pre-treatment platelet count of less than 1 lakh and AST more than 48 and higher ALB score, that is less than 2.5, and follow-up AFP more than 4.8, and we suggest to do an abbreviated MRI for at least patients who are high risk, so that we can get an early diagnosis and treatment for these patients.
Thank you, Dr. Tanush. So you started in the introduction saying that there was some controversy initially about HCC
Yes.
after hepatitis C treatment.
Post-DAA, initially they said that
So
DAA...
are your findings in line with controversy or
No.
disproving them?
No, we are not finding in line with the controversy, sir, because DAA still holds this most commonest reason why the patient developed is possibly a missed out dysplastic nodule before the start of DAA is the commonest reason we have seen, sir. So that is why we had advised an abbreviated MRI for patients who are all at high risk in those cases.
So if we, at the start of DAA therapy, if we did everyone an MRI or a CT, it's possible we may have found early undetected hepatocellular carcinoma or pre-neoplastic lesion.
Pre-neoplastic lesion,
But
yes.
in your protocol, currently you're not doing that.
No, this is a retrospective study, sir. So only all those patients who have developed HCC, I'm going back and seeing what were the risk factors which was possibly there, sir.
Fair. Thank you.
Thank you, sir.
Thank you. Next we go on to Dr. Janavi Sridhar. Please come and make your presentation.
Good morning to one and all. Today I'll be presenting a study that I did with my colleagues in the Department of Hepatology, Sri Ramachandra Institute of Higher Education and Research, on the prevalence and risk factors of metabolic associated fatty liver disease. So it's a well-known fact that non-alcoholic fatty liver disease, or NAFLD, along with its metabolic components, are a major cause of chronic liver disease, including cirrhosis in patients. And given the importance of these metabolic components, a new terminology of metabolic associated fatty liver disease, or MAFLD, has been introduced, which is basically defined as the presence of fatty liver in addition to at least one of the following metabolic features, namely obesity or overweight BMI, type 2 diabetes mellitus, and metabolic dysfunction. So keeping this in mind, the aim of our study was to determine the prevalence and determinants of MAFLD in patients screened in the master health checkup in our college. So for the patients arriving at the master health checkup between October and December 2022, we collected demographic data, anthropometric measurements, and laboratory investigations for dyslipidemia, blood sugar levels, and liver biochemistry, and imaging for ultrasound and fibroscan for fatty liver. All patients above the age of 18 of either gender, with or without components of MAFLD, were included, and they were screened for presence of other causes of liver disease like hepatitis B and C virus infection, current use of or significant consumption of alcohol, and drug-induced liver injury. Ethics committee approval was obtained for this study, and appropriate statistical analysis methods were done using MD calculator. We took a p-value of less than 0.05 to be statistically significant. Of the 321 patients we saw, 272 of them met the inclusion criteria for the study, 167 men and 105 women. We excluded 49 patients. The number of cases we found matched the number of controls. 139 out of 272 patients had fatty liver. And the prevalence of MAFLD in overweight or obese patients was 59.1%, while that in type 2 diabetes mellitus patients was 66.9%. Coming to the demographic variables, we found that male gender, weight in BMI of greater than 23 kg per meter square, and hypertension, waist circumference of greater than 90 centimeters in males were found to be statistically significant. Among the individual categories of the metabolic associated fatty liver disease, we found that BMI and type 2 diabetes mellitus were significant contributors to MAFLD in this population with an odds ratio of 3.414 and 3.24 respectively. Among the individual components of metabolic dysregulation as per the APASL guidelines, hypertension, waist circumference in men, raised serum triglyceride levels were found to be statistically significant with an odds ratio of 1.97, 5.22, and 3.18 respectively. So to summarize, we found that the prevalence of MAFLD is significantly contributed to by overweight or obese BMI, waist circumference of greater than 90 centimeters in men, diabetes mellitus, and raised serum triglyceride levels. The strength of our study is that we have addressed the prevalence of MAFLD in a hospital-based population in the absence of other contributors to liver disease like alcohol consumption and drug-induced liver injury. There were some limitations. Firstly, that our sample size was relatively small. We conducted a cross-sectional study where a longitudinal study may have been more informative. Grades of fatty liver were not available in many patients. And we were unable to capture lean MAFLD, which is an entity characterized by a BMI of less than 23 with the presence of metabolic dysregulation. And we were unable to do this because we didn't have HOMA-IR and HSCRP levels for many of the patients. So to conclude, there is there's continuously evolving nomenclature of fatty liver disease from a diagnosis of exclusion, non-alcoholic fatty liver disease, to a diagnosis of inclusion, like MAFLD, genetic associated fatty liver disease, and so on. So the implications of these are future perspectives that can be studied in later on. Thank you all for your kind attention.
Thank you for this presentation. I understand you are a third-year medical student. So
Yes, sir.
let me first of all appreciate your enthusiasm and coming in.
Thank you, sir.
So, NAFLD and MAFLD is a controversy, non-alcoholic versus metabolic. So the name suggests that in metabolic MAFLD, one does not need to exclude alcohol.
Yes, sir.
But in your study, you have excluded alcohol.
Yes, sir.
Is that, what's your stance?
So initially, when we began this study, we started by excluding patients with alcohol consumption because we weren't sure how to quantify the alcohol consumption accurately based on the patient history. So from October to December, when we were conducting it, for the sake of uniformity, we excluded patients with current alcohol consumption, sir. But in the future, as we extend the study, we would like to include all patients regardless of their alcohol consumption. Thank you, sir.
Dr. Srividya Manjunath. Can she come for her presentation, please?
Very good morning to everybody. My topic today is efficacy of plasma exchange in patients admitted with alcohol-induced acute on chronic liver failure. So we know that acute on chronic liver failure is a distinct entity. It is an acutely decompensated chronic liver disease. It is characterized by intense inflammatory response and, more importantly, single or multiple organ failure, and has very high short-term mortality. There are various definitions according to different international consortia, but most commonly used ones are the ESIL and the APASIL consensus. ESIL says the patient can have a previous episode of decompensation. They accept both intrahepatic and extrahepatic insults. The APASIL, on the other hand, has patients who have diagnosed or undiagnosed cirrhosis presenting with the first-time decompensation and more of an intrahepatic insult. The degree of ACLF is again based on the degree of organ failure. It is graded as 1, 2, and 3 based on how many organs and how severe the organ failures are. The issue with ACLF, again, as we know, is very high short-term mortality. It averages between 30 and 50%, and as the severity of the ACLF increases, the mortality increases. As in grade 3 ACLF, the 28 and 90-day mortality can be as high as 74 and 78%. The treatment for ACLF as such can be just organ support in the form of ventilation, vasopressors, or renal replacement therapy. But ideally, all these patients will require liver transplant. And in an ideal situation, it is preferred that the grade of ACLF comes down between day 3 and day 7 of admission. But this is not a situation that can be applied to all patients in all hospitals. And patients who have been decompensated because of an insult because of alcohol and alcohol hepatitis, secondary to organ failure, they do not become candidate for steroids. So without being able to give steroids and not being able to immediately proceed for transplant, is there something in between that we can do for them that might be able to support their organs or maybe improve the survival, is what we wanted to see. So the aims of our study was to assess the benefit of plasma exchange in patients with alcohol-related ACLF. What was the short-term survival in these group of patients, and if they did respond to plasma exchange, what were the factors that responded, and what were the issues that did not respond to plasma exchange. So it was a single-center observational retrospective study. We looked at the data on plasma exchange done in patients between 2019 and August 22. ACLF was diagnosed as per APASIL criteria. And we excluded patients with ALF, refractory shock, patients who require renal replacement therapy, and severe cardiac dysfunction. So we do plasma exchange by the femoral axis by the centrifugation method, a low volume plasma exchange. We use FFP as replacement fluid and 3 to 5 cycles depending on the patient's response. And our indications for plasma exchange initially was organ failure in the form of acute kidney injury or bile cast nephropathy, encephalopathy, or worsening coagulopathy or bilirubin. So totally 20 patients were included. All our patients were male. All had a history of significant alcohol and alcohol hepatitis presenting for the first time with decompensation. They had no significant comorbidities. The viral serology was negative, and they did not have any past history of exposure to steroids and native medications. Average age was 40 plus minus 11 years. Bilirubin was 26 plus minus 7 milligrams, and INR was 2.4 plus minus 0.8. Only 10% of our patients had grade 1 ACLF. Majority of them, 70%, were in grade 2 and 20% were in grade 3. And 14 of these patients did not have encephalopathy. 3 had low-grade encephalopathy, and 3 had grade 3 to grade 4 encephalopathy. So at the end of plasma exchange, at the end of hospitalization, 75% of our patients survived. 4 patients deteriorated, sorry. They had worsening encephalopathy and sepsis, and 1 patient died at the index admission. So we looked at what was the difference between those who survived and those who didn't. The admission bilirubin, INR, and creatinine were not significant. However, those who had more severe grade of encephalopathy requiring ventilation, they did not survive much. And the admission MELD was not significantly different between both groups, but in those who did respond to plasma exchange, the drop in MELD was statistically significant. Then we looked at the change in the grade of ACLF, and here if you see, At admission, only 2 patients were in grade 1 ACLF and 14 of them were in grade 2. But post plasma exchange, there was a drop in the grade of ACLF that more patients became grade 1. Only one of the patients who was in grade 3 became grade 1 ACLF, but the other 3 who were in grade 3, they did not respond, remain in grade 3 ACLF. And we looked at the ARC score, and in that, if you can see here, the patients who had more significant encephalopathy, grade 3, grade 4 requiring ventilation, the pre and post plasma exchange ARC scores were not very different.
Can you conclude, doctor?
Sure, sir. The other important thing was most of our patients had acute kidney injury, and 50% of them who had bile cast nephropathy, and we saw that acute kidney injury responded very well to plasma exchange. In most of these patients, it normalized, and even in those who did
Doctor, I
not
think
normalize, at least it improved.
You have to conclude your
Sure,
finding.
sir.
Can you just conclude your study? What are your conclusions based on this study?
The conclusions based on the study are the plasma exchange may have a role as a bridge in patients who have acute and chronic liver failure, at least in the form of organ support where acute kidney injury or the grade of ACLF might come down post the plasma exchange. The survival, however, was not significantly improved compared to historical controls or past studies.
What do you think is the limitation of your study here?
Sir, it's a single center study. It's a very small group. We did not have a comparative control group to see whether it was any different between the treatment and the standard medical treatment.
Yeah, it seems to be a very select group where you have not initiated any patients on, did not have much of a renal failure. I think 1.82 creatinine is fairly okay for us to manage. And most of these patients were in ACLF grade 1 and grade 2.
2, sir. 2 more than.
Did you biopsy these patients before doing
No,
that?
sir. All of them had ascites and coagulopathy, so they were not candidates for biopsy. We don't have transjugular, so we didn't do.
Was there any concomitant steroids used with this patient?
No, sir. We didn't use. Most of them had renal failure, so we did not use steroids on anyone.
And what about the infectious screening in these patients?
All patients who have ascites will be screened for SBP. Urine cultures and blood cultures were done before initiating plasma exchange.
So what really, at what point of level, at what level of plex did you determine whether to continue plex or not do plex?
Sir, if the renal failure responded, if the encephalopathy became better, if the coagulopathy improved, then we stopped.
Because between the survivals and the non-survivals, there's not much of a difference in
Not
the
much difference.
MEL score. Okay, thank you.
Next, Dr. Ashish Kumar Sautri.
Good morning, everyone. I am going to present our study, the clinical profile and outcomes of cytomegalovirus colitis infection in patients with ulcerative colitis flare. So, CMV infection increases the colectomy and mortality rates in patients of ulcerative colitis flare. Hence, the diagnosis of CMV colitis is crucial in deciding the need for antiviral treatment. So, the aim of our study was to find out the prevalence, risk factors, and the outcomes of CMV colitis in patients who were admitted with ulcerative colitis flare. So, we included all the patients who were admitted with UC flare, underwent evaluation for CMV infection, and had documented outcomes between May 2010 to June 2022. And the data was collected from the inpatient records. Analysis was done with respect to the clinical presentation, diagnostic profile, treatment, and outcomes. The study was IRB approved. So the diagnosis of CMV was based on positive result of any of the following 3 tests, either CMV PCR in the colonic biopsy, blood PCR, or colonic histopathology showing evidence of CMV inclusion bodies. Patients who had inadequate response to steroid therapy were treated with antiviral drugs based on the discretion of the treating clinician. The continuous variables were interpreted as mean with standard deviation and was analyzed by t-test, and the discrete variables were interpreted as proportion and was analyzed by chi-square test. Total number of 302 patients with UC flare were included in our study, out of which 127 patients, that is 42% of the patients were positive for CMV by either of the following 3 tests. The rest of the patients were CMV negative. Out of the total 127 CMV positive patients, 27 patients did not respond to initial steroid therapy and ended up in requiring treatment with antivirals. Coming to the baseline characteristics, in both the groups, most of the patients were in the fourth decade of their life. The female in both the groups were around 40%, and the extent of disease in both the groups was predominantly extensive colitis that accounted for around 70% of the cases. The mean UCAA score in the CMV positive group was 4.9, and the CMV negative group it was 4.3, and the difference was statistically significant. There was no significant difference in the mean hemoglobin, mean total leukocyte count, mean absolute lymphocyte count, and mean CRP levels. The albumin was significantly lower in the CMV positive group as compared to the CMV negative group. And when we compared the use of different drugs in the recent past, the CMV positive group had increased use of oral steroids, which was statistically significant as compared to the CMV negative group, but there was no significant difference in the use of oral ASA therapy and immunomodulators like azathioprine. Coming to the outcomes, we defined composite poor outcome as a combination of colectomy, death, and the discharge against medical advices. So there was no significant difference in the composite poor outcome between the two groups. When we analyze individually the colectomy and death rates, there was no significant difference between the two groups. However, the mean duration of hospital stay was 3 days higher than the 3 days higher in the CMV positive group as compared to the CMV negative group, and the difference was statistically significant. So around 79% of the patients who had CMV infection improved without any antiviral therapy. 75% of the patients who required antiviral therapy showed clinical improvement. And 52% of the patients, despite having evidence of CMV inclusion bodies in histopathology, improved without any antiviral therapy. So when we see the other studies, one last multi-center study from China, which included more than 4,000 patients, out of which 150 patients were positive for CMV, the composite poor outcome was 42.6%. Similarly, another study from Turkey showed higher colectomy rates and lower clinical remission rates in patients of CMV positive as compared to the CMV negative ones. But our study showed a better clinical outcome in patients with CMV infection in UC flare. So the strength of our study, it was the study from India with highest number of CMV positive UC flare patients. The limitations were it was a retrospective single center study and the follow-up data was incomplete. So I would like to conclude by saying that the prevalence of CMV colitis in our study was 42.1% in patients with UC flare, and the patients who were CMV positive had higher UCAA score, low albumin levels, and increased use of oral steroids. The clinical outcome between the CMV positive group and the CMV negative group was similar, and significant proportion of the CMV positive patients improved without any antiviral therapy. Thank you all.
Thank you, Ashish. I have one problem. Your diagnosis of CMV, you said even a blood was used to diagnose. You said tissue was used to diagnose and also regular histology.
Yes.
But you cannot make a diagnosis of CMV on a blood test because CMV is there in most people. So the blood antibodies will be positive. So that is the reason probably why you have such a high level of
We have taken as blood CMV PCR.
Yeah, even blood CMV PCR is not diagnostic of a CMV responsible for the flare. You must have colonic histology which shows CMV there in the acute phase. Only then can you make a diagnosis.
But
how many were histology proven in this and how many were blood test proven?
So 22% of the patients there was inclusion bodies in the histology, and the CMV tissue PCR was positive in 98% of the patients.
CMV?
PCR, tissue
Yeah,
PCR.
that is not, that cannot be taken as a diagnosis of CMV. Only the histology can. But you can, in follow-up, you can use the blood test to know whether your CMV is under control, your drugs have been useful. So that is, I think, a flaw in this study.
This was a cross-sectional study, right? That's one point of study.
No, ma'am.
Is it a follow-up study? How many were followed up?
Ma'am, the follow-up data was not completed.
Retrospective. So when the patient came to you on day one, all patients were screened for CMV?
Yeah, ma'am.
All patients were screened for...
We included those patients who underwent evaluation for CMV infection.
You also didn't give us data on what are the other causes of the flare which you check. the stool test, the,
stool routine
the
parasites,
Clostridium difficile.
stool routine parasites and Clostridium difficile, stool culture.
Okay. Okay, thank you, Ashish.
Call upon Dr. Arvind.
Good morning, everyone. I'm Dr. Aravind from Gleneagles Global Health City. I'm going to present a study which was conducted in our hospital, which was aimed towards predicting the survival of HCC following TACE procedure. I would like to thank my professor, my senior, and my colleagues who are involved in the study and who helped me through this study. The aim was to analyze the predictors of survival following TACE procedure in hepatocellular carcinoma who had chronic liver disease. So it was a retrospective observational study conducted between January 2020 and December 2021. And 94 patients who were chronic liver disease patients with hepatocellular carcinoma who underwent TACE procedure were involved. Patients who had extrahepatic metastasis at diagnosis, who had HCC following surgery, and who had underwent SBRT, immunotherapy, or prior TACE, microwave ablation, or radiofrequency ablation, were excluded from the study. And the demographic data, clinical biochemical parameters of severity of chronic liver disease, tumor characteristics were enrolled at the time of entered at the time of enrollment, and all patients were followed up for a minimum period of 12 months. The number of TACE procedure, peri-procedural complications, and response to TACE were entered. All patients who underwent TACE were started on lenvatinib. And the study group was divided into two subgroups based on the survival. And statistical analysis was done using SPSS software. And this is our institutional protocol, radiological surveillance protocol. That is, once the patient undergoes TACE procedure, we will ask the patient to come back with a CCT abdomen after 1 month. If there is an increase in size or if there is a new lesion, we'll subject the patient to a repeat TACE, and we'll follow up the patient after 1 month with repeat CCT abdomen. And if there is no increase in size or if there is no new lesions, we'll ask the patients to repeat a CCT abdomen after 3 months. Since there is a higher risk of recurrence of HCC, that is more than 6.5 times the risk involved following the first TACE during the first year of surveillance, we generally ask the patient to do frequent radiological surveillance during the first year. Our institutional protocol coincides with the study which was conducted by Edward Boas et al., who suggested that frequent, that is at least once in 2 to 3 months during the first year of following TACE procedure, the patient has to be subjected to radiological surveillance. This was published in Journal of Vascular and Interventional Radiology in 2015. So these are the results of our study. The mean age of our study population was 63.85 years, and males were predominant, and the most common cause of chronic liver disease in our patients were viral etiology, followed by ethanol and NASH. And many of them were diabetic and hypertensive. 48 patients were belonging to CTP-A, and 40 belonged to CTP-B, and 6 belonged to CTP-C. And 49 patients were within UCSF criteria, and 45 were beyond UCSF criteria. And 74 patients underwent single TACE, and 20 patients underwent multiple TACE procedures. So this is a table which compares the demographics of both the groups. That is, this clearly shows that demography did not have a significant influence in survival. That demographic data like the mean age, etiology, and the comorbidities did not have any significant influence on the survival. And this is a table which compares the prior decompensation events in both the groups. There was no statistically significant influence. And this table shows that CTP-C patients had a statistically significant increase in number of deaths, and UCSF criteria number of sessions of TACE and vascular invasion had a statistically significant influence. So this is a Kaplan-Meier chart which shows there's a very significant increase in the median survival days in patients within UCSF criteria compared to patients with beyond UCSF criteria. The mean age of survival within UCSF criteria is mean duration of survival is 332 days, and beyond UCSF criteria it is 257 days. And patients who underwent single TACE procedure had a mean survival period of 209 days compared to 434 days who underwent multiple TACE procedures. And the severity of liver disease in both the groups were not statistically significant. And 12 patients had complications.
Doctor,
9 had transient.
Can you conclude, doctor, please?
Yes, sir. So our conclusion is that TACE remains to be a feasible option for patients with preserved liver function. And UCSF criteria predicted survival. That is, even if the patient, even in our study, it has been shown that within UCSF criteria, patients survived better. But even patients beyond UCSF criteria had a median survival period of more than 260 days, which is almost equal to a year. So TACE can be considered as a potential treatment for patients beyond UCSF criteria. And subsequent.
What purpose? As a bridge to a liver transplant, or
as a bridge to,
it's going to be a survival benefit?
As a bridge to liver transplant as well, ma'am.
So how many of your patients in the type C were listed for CTPC were listed for liver transplant?
6 patients were belonging to CTPC group, ma'am. One underwent transplant, he survived.
You could downstage?
We could able to successfully downstage one patient, and he's surviving, ma'am. Now, he underwent multiple TACE procedures. I mean, he underwent 3 TACE procedures and he survived.
Why was UCF score used instead of the Barcelona modified score? Why did you consider UCF rather than Barcelona is what we are familiar with?
We used UCSF criteria regularly, ma'am.
Sorry?
We generally use UCSF criteria to in our institution.
To stratify the patients for management, would you consider the BCLC scoring or?
For management, we generally we have our own institutional protocol.
That's what UCSF is for transplant. So in your patient, when you're that means you're already listed for transplant, and then you're categorizing the patients, right?
Yes, ma'am.
So what was the Barcelona the BCLC score?
BCLC score, the data is available, but I didn't put it here, ma'am, actually. We do see Barcelona.
The last question is, the TACE that you mentioned, you said complete response or no response. What were the partial responders? What was your take? The ones who had a partial reduction.
We subject them to subsequent TACE procedures based on their secretory functions, ma'am, subsequently.
So you used lenvatinib for all these patients?
Sorry, sir?
No, all these patients were put on lenvatinib.
Yes, sir.
And what was the average size of the tumor you did TACE?
It was around 4 centimeters.
4 centimeters. And do you think lenvatinib has had an impact?
No, sir. Most of the patients lenvatinib did not have very significant influence in the study because all were subjected to lenvatinib therapy. So only TACE is the number of sessions of TACE is the difference in both the groups.
Thank you, doctor.
Yes.
Dr. Dinesh Jyotimani, next presenter. Anyone from his center? Okay, I think he's not there. Dr. Raghavendra.
Good morning, everyone. I am presenting a paper on study on the outcomes of therapeutic plasma exchange in hepatotoxicity due to rat killer paste poisoning. Introduction. Elemental phosphorus is a non-metallic substance that exists in 2 common forms. The red form has a very limited toxicity. White form as a highly toxic compound can cause hepatocellular necrosis and acute hepatic failure. Therapeutic plasma exchange is a removal of the patient's plasma and replacing it with the plasma from donor along with the colloid by using extracorporeal device. There is a limited data on the efficacy of the therapeutic plasma exchange in patients with ALF due to yellow phosphorus. Aim was to study the outcomes of plasma exchange in patients with yellow phosphorus induced acute hepatotoxicity. Study was a retrospective study conducted in the Department of Medical Gastroenterology, Stanley Medical College from August 2020 to August 2021. Study population was all rat killer poisoning patients admitted during the study mentioned period who developed hepatotoxicity and underwent therapeutic plasma exchange. Exclusion criteria: patients who have taken yellow phosphorus along with other hepatotoxins and patients who have underlying chronic liver disease. Epidemiological data, LFT values, number of plex sessions underwent were collected from the rat killer poison register, and the improvement in LFT coagulopathy after each session of the plex and outcomes were analyzed. Indications for the plex were in a patient with rodenticide with presence of deranged LFT or any of the three following criteria: INR more than 4, worsening of INR on serial investigations, and depressed level of consciousness. Statistical analysis was done using IBM SPSS version 23 with p-value less than 0.05 is considered significant. Results: total of 507 patients with yellow phosphorus poisoning admitted during the study period. Out of them, 116 patients underwent plex were included in the study. 57 were males, 59 were females. Most were in the age group of 18 to 30. Baseline characteristics: mean age at the time of admission was 27 years, and the mean day to get admission to the hospital was 3.9 days after consumption of yellow phosphorus, and the mean time to start the first session of the plex was 6.1 days. And the majority of the patients presented to us with hepatic encephalopathy. Around 42 patients were in the normal sensorium. Around 60 patients have taken less than 15 grams of yellow phosphorus. Out of them, 15 were expired. And 43 patients have taken 15 grams of yellow phosphorus, and 15 of them are expired. And 10 patients have taken 30 grams, and 3 of them are expired. And 3 patients have taken 45 grams of yellow phosphorus, and 2 of them are expired. Mean bilirubin at the time of admission was 7.4, which initially increased to 8.89 after first and second plex, and it reduced to 6.1 after third session of the plex. Mean SGPT at admission was 626, which gradually reduced to 101. And mean INR at admission was 4.1, which gradually reduced to 1.3 after third session of plex. There is a significant improvement in LFT and PTNR after each session of the plex. This is the flowchart showing the SGOT, SGPT significant reduction after each session of the plex. And again, the total bilirubin initially increased, and after third session of the plex, there is a significant reduction in total bilirubin, and INR is also significant reduction after each session of the plex. This is patients who recovered from the acute liver failure with plex showed significant improvement in LFT, SGOT and SGPT as compared to patients who didn't recover from the LFT. Outcomes: out of 116 patients, 80 patients recovered while 35 patients expired. High dose, late presentation were associated with poor outcome. Calculated lethal dose of yellow phosphorus was 1 milligram per kg. In the current study, all patients have taken more than lethal dose. Most of the patients developed jaundice, hepatic encephalopathy, bleeding manifestation after day 3 of admission. Subgroup analysis of baseline characteristics at admission showed higher HE, high dose of yellow phosphorus, late presentation resulted in poor recovery. The treatment of yellow phosphorus is aimed at removal of the poison, prevent absorption. N-acetylcysteine in the treatment of ALF is due to ALF due to yellow phosphorus is still to be validated. Recent studies suggest that plex as the first line therapeutic option in the management of ALF. Our study showed 70% recovery from ALF with mean plex session of 2.8, and the mean time to get admitted to the hospital 3.9 days, and mean time to start the plex was 6 days after. There is significant difference in various liver parameters.
Give your conclusion.
Yes. Therapeutic plasma exchange is a viable treatment option in yellow phosphorus-induced acute liver failure with better outcome in poor resource settings where liver transplant is.
So in your patient, most of the patients came on day 6, the mean time, no?
Day 3.9 days.
No, I thought you said, yeah, 4th day.
Yes, ma'am.
As you were mentioning, it seemed as it was 6th day.
Yes.
So how did you compare the ones who came within, say, 24, 48 hours versus those who came a little later? What was the outcome in these two groups?
Patients who presented early
Now, early means how early did they present? What was the main early presentation versus the late presentation?
Day 1 also some patients have presented, ma'am.
So I just want to know day 1 to 3 versus after 3 days. Our problem is on day 3, when the patients come on day 3, should we start the patient on Plex or not?
As soon as they develop the indications for the Plex, ma'am, as soon as they altered LFT with the worsening
So
of the INR.
so you wait basically for the LFT to
Yes, ma'am.
start.
Yes, ma'am.
What about INR?
INR is also more than 4 and worsening on serial investigations, ma'am.
Okay, any questions?
I must congratulate Stanley for this must be the largest series of Plex treated rat killer. I have a question for you. Do you think the Plex is removing the poison or the Plex is addressing the immune response in this patient? What's your sense?
Maybe removing the toxins and other high molecular weight compounds like 1 milligram factor. Thank you, sir.
Was there a quick question? Was there an impact of encephalopathy on these patients and the outcome of Plex? And you defined acute
Yes,
liver
sir.
failure.
Initial presentation with encephalopathy had poor outcome in the response.
And the consumption is pretty high,
Yes, sir.
1 gram. In fact, we see ALF even with 7.5.
Yes.
Thank you.
Thank you, sir.
Dr. Nishant?
Good morning, everyone. Good morning, judges. My topic today is about portal vein thrombosis. Is it really common? Now let's have a look. Portal vein thrombosis is one of the most important causes of portal hypertension. At initial diagnosis, it is important to distinguish between a cirrhotic versus a non-cirrhotic portal vein thrombosis, whether the thrombosis is an acute or a chronic, and the anatomical extent within the venous system. This distinction is critical as the evaluation, prognosis, and treatment are different. The aim of my study was to determine the etiology, clinical characteristics, sites of portal vein thrombosis, and to identify the risk factors associated with portal vein thrombosis in patients attending a tertiary care hospital. It is a retrospective observational study with 102 patients with portal vein thrombosis during a period of 18 months. 102 consecutive patients with portal vein thrombosis were studied. 57.8% were male with a mean age of 56 and 42% female with a mean age of 63. Coming to the clinical presentation, 55.8% of the patients had a recent onset acute thrombosis. Chronic portal vein thrombosis was seen in 44% of the patient. The common clinical presentations included GI bleed, abdominal pain, abdominal distension, ascites, jaundice, and hepatic encephalopathy. 46% of the patients had varices on endoscopy. However, only 23% presented with a GI bleed. Among the patients with cirrhosis, 10% were in child A, 50% in child B, and 40% in child C. Splenomegaly was seen in 60% of the patients. Coming to the sites, portal vein was only involved in 66%. Portal vein, superior mesenteric vein was involved in 10.8% of the patients. Portal vein along with the splenic vein was involved in 5.9%, and all three veins were involved in 16.7% of the patients. Coming to the etiology, 10 cases had underlying malignancy, of which HCC was predominant. 40 cases had underlying cirrhosis, of which alcohol was the most prominent etiology. EHPVA was seen in 20% of the patients, 20 cases, and a prothrombotic state was seen in 12 cases in predominantly non-cirrhotic patients, with JAK2 positive being the most common mutation. Patients also had underlying severe pancreatitis in 8 of the cases, and the rest of the causes were idiopathic. As you can see, cirrhosis was the most common etiology for portal vein thrombosis, followed by EHPVO and an underlying prothrombotic state. Treatment and prognosis. Over a 3 to 6 month follow-up, 42% of the patients received anticoagulation, of which 35% achieved recanalization. 27% required readmission due to the 3 to 6 month follow-up, whereas 16% succumbed either due to GI bleed or surgical related complications, and 15% was stable during the follow-up. The discussion, 40% of patients were cirrhotic in our study compared to 26% in other studies. Alcohol was the most common cause in cirrhosis in our study compared to hepatitis B in other studies. Alcohol-related cirrhosis was the most common etiology, underlying etiology for portal vein thrombosis in our study compared to HCC in other studies. EHPV was seen in 20%, whereas in 17% in other studies. Splenomegaly in 60%, and whereas in 40% in other studies. 12% of the patient had a procoagulant state, which was predominantly JAK2, whereas in other studies it was APLA. The clinical presentation was similar. 35% of the patients had a recanalization following anticoagulation. In other studies, it was around 38. And there was a 15% mortality during the follow-up period in our study compared to 20% in other studies. So the conclusion, it is important to define the portal vein thrombosis, underlying etiology, extent, and timing, as they are central to estimating the prognosis and to aid therapeutic decision making. Early diagnosis and intervention is key. Anticoagulation improves recanalization and disease mortality. Conventional procoagulant workup can be done based on the individual situation. Screening for thrombophilia is not generally recommended or cost effective in patients with cirrhosis and portal vein thrombosis, but however, it's based on the clinical situation. Transplant listed patients require prolonged anticoagulation. Hypercoagulable states require indefinite anticoagulation. Suspect vascular thrombosis and new onset worsening ascites or decompensation or abdominal pain. Regular surveillance might be required for high-risk patients, and tips can also be considered. Future perspectives include role of anticoagulation in cirrhotics and their efficacy, safety, and their survival benefits based on the different anticoagulants. The role of tips in patients with portal vein thrombosis and portal hypertension and their survival benefit can be studied. So overall, a multi-center collaboration might be needed to develop current Indian guidelines. These are my references. Thank you.
So, I have a question for you.
Yes, sir.
How do you identify portal vein thrombosis in patients with extrahepatic portal vein obstruction?
So usually by imaging, sir.
Sorry?
Higher imaging, sir.
No,
CT.
so when you say extrahepatic portal vein obstruction, what did you have in mind?
I didn't get your question, sir.
These are patients with extrahepatic portal vein obstruction.
Yes, sir. Or
So the
intrahepatic.
portal vein is already replaced by a leash of collateral.
Yes, sir.
So are you talking about the thrombosis in the leash of vessels which replaces the portal vein?
Yes, sir. Including every extrahepatic, intrahepatic, including other vascular, even the superior mesenteric vein, splenic vein. Mainly the portal vein.
So there was you know that this person had a splenic vein thrombosis initially, and you're saying there's a new thrombus in the portal vein. Is that correct?
So it was a retrospective study. We
So
took
how-
all the.
So my question is, in a patient with extrahepatic portal vein obstruction, how do you say that he's got a fresh onset portal vein thrombosis?
Fresh onset, we look at the collaterals, sir. If we see the collaterals, we more go towards a chronic. And if it's an acute, and we do.
All right.
Thank you, Doctor.
Thank you. Thank you.
Move on to the last presentation by Dr. Krishna Bharadwaj.
Good morning, everyone. Today I am going to present our study titled, In Context of an Algorithmic Approach, Direct glue injection is comparable to US-guided interventions for management of bleeding isolated gastric varices 1. As we all know, selection of therapy for IGV-1 will depend upon the individual patient profile, availability of expertise, and resources. This study is aimed to assess various modalities used in the treatment of bleeding IGV-1 and to compare US interventions with direct glue injection in the terms of rebleeding, complications, and in-hospital mortality. The methods we used were all patients with bleeding IGV-1 undergoing direct index intervention during 2014 to 22 were retrospectively studied. Baseline characteristics intervention details, and follow-up data were obtained from discharge summaries and chats. The outcomes studied were early rebleeding, which is defined as per the IST task force of COOR consensus, late rebleeding as overt bleed after 5 days and within 3 months of the index therapy, in-hospital mortality, complications of therapy, and duration of hospital stay were also studied. This is the stepwise approach for the management of bleeding IgV1, which is followed in our department, and any patient with a history of bleed and IgV1 noted in the gastroscopy will be looked for active bleeding. If the patient is actively bleeding, EUS intervention will be offered if the expertise is available and patient consents for the same. And any patient without active bleeding will be offered a radiological procedure, BRTO, if there is a shunt amenable in a cross-sectional imaging. Rest all other patients will undergo direct glue injection. Statistical analysis were done using a standard descriptive statistical methods, and propensity score matching was done for age, CTP score, and timing of endoscopic intervention to minimize the selection bias in the observed data. This is the patient flow in the study, and there were total 146 patients who underwent index interventions during the study period, out of which 117 underwent direct glue, 16 underwent EUS interventions, and 13 underwent BRTO and TIPS, 11 specifically BRTO. This is the baseline characteristics of the main cohort. As we could see, there is a statistically significant difference in sex as well as the timing of intervention. The EUS guided interventions are predominantly done more than 48 hours of the index bleed, and direct glue injection was done less than 48 hours of the index bleed. And there are majority females in the EUS intervention group, males in the direct glue group. And alcohol was found to be most common in the direct glue group. So to minimize this observed bias, propensity matching was done for age, timing of intervention, and child score. And the baseline characteristics after matching 32 patients in direct glue group with 16 patients in EUS intervention, the baseline characteristics were found to be similar, including the number of packed cells transfused prior to the therapy. So the outcomes we studied were early rebleeding. 4 patients got early rebleeding after getting a direct glue injection, and none after a EUS group. But there was no statistically significant difference for this observation. Late rebleeding, 2 patients in EUS group had late rebleeding, and 3 patients in the direct glue group has late rebleeding. And there was no statistically significant difference in late rebleeding and overall rebleeding between both the groups. 1 patient died in hospital after direct glue injection, and none in the EUS group. And there was no procedure-related complications in both the groups. The mean duration of hospital stay was also found to be similar in both the groups. This is the overall flow chart of the patient inflow in the study. Out of 146, 117 has direct glue injection, and 17 were found to have early rebleeding, and out of them 6 died. And there was a loss to follow-up in the data. 22 patients were not having 3-month follow-up in the direct glue group. 1 in EUS, 1 in BRTO, 1 in TIPS group didn't have a 3-month follow-up data. And there was no early rebleeding in any of these groups. 1 patient in BRTO had a late rebleeding within 3 months. So the discussion, the strengths of the study, is the first study in India to compare the index interventions for bleeding IgV1, and it is a real-world data analyzed with propensity matching. However, there are limitations like small sample size, single-center retrospective analysis, and there was a high number of loss to follow-up. To conclude, I will say in a real-world setting and an algorithmic approach, direct glue injection is comparable to EUS-guided interventions in terms of rebleeding and mortality. However, large prospective randomized trials are needed to validate these findings. Thank you for your kind attention.
Thank you. When you chose your patients, at least for coil plus glue,
Yes, sir.
it was only people who gave consent.
Yes,
People
sir.
didn't give consent,
Were
you
given
gave
glue.
glue.
Yes, sir.
So it was really not a randomized thing, it
Yes,
was a
sir.
retrospective thing.
Yes, sir.
And the numbers in the glue plus coil is very small compared to your glue. So that might create only 16 patients versus 100 plus patients in there.
Yes, sir.
So that is another limitation of your study.
Yes, sir.
And what you found is that both are similar.
Both are similar if you follow a standard approach and if you match the patients. Like US is usually done in a more stable patients generally, but if you can do the same patient, direct loop, it may have a similar effect.
Any questions? Thank you.
Thank you so much, sir.
We congratulate all the participants who have made their presentations today. It was a wonderful presentation, and we look forward for an original paper from all these 9 papers that were presented today, because most of these presentations do not work up towards the publications. We look forward to that, and with that we conclude the session. Thank you. Wishing all the candidates all the best.
Thank you, chairpersons, and thank all the speakers. An announcement. I request all the dignitaries to sign in the register in the registration desk to avail the TNMC credit points. Moving on to our next session, Gastro Upgrade Session 3. The chairperson of the sessions are Dr. M.S. Revati and Dr. Porselvi, Dr. A. Mohan Krishnan, and Dr. R. Karthikayan. I request all the chairpersons to take the chair on the dais.
Welcome you all for the Gastro Upgrade Session 3. So having 3 speakers now. First topic is pancreatic necrosis, current approach by Dr. Sudipta Dar Chaudhary.
Good morning, respected chairpersons, respected teachers and friends. At the very outset, I would like to thank Indian Society of Gastroenterology Tamil Nadu chapter for giving me this opportunity. Today, I'll speak briefly on pancreatic necrosis and the current approach to its management. Now, acute pancreatitis, as you all would appreciate, is one of the most common emergencies that we face as gastroenterologists. Most of the patients come in with mild acute pancreatitis. However, 15 to 20% of the individuals progress to moderately severe or severe acute pancreatitis. And the forms of pancreatitis are usually majority include interstitial edematous pancreatitis, and a small percentage do have necrosis, and we call them necrotizing pancreatitis. The fluid collections in pancreatitis have been classified as per the modified Atlanta into those like acute pancreatic fluid collections developing an interstitial pancreatitis within 4 weeks, and how to get a pointer? Okay, that's okay. So, and acute necrotizing collections. After 4 weeks, they organize to form a pseudocyst or a Waldorf necrosis. Now, talking of pancreatic necrosis, majority of them continue to remain asymptomatic and probably resolve without any interventions. And spontaneous resolution is seen to occur at least in 30 to 40% of the individuals. However, complications can develop in a small subset of these individuals, and the complications can be in the form of infection, pain, bleeding, or rupture. For the purpose of today's discussion, I'll restrict my talk primarily to the management of infected pancreatic necrosis. Now,
when do you intervene in pancreatic necrosis? Now, these are the guidelines which we got together from the India EUS Club and Society of Gastroenterology and Endoscopy of India. So the indications are proven infected collections, that is with an FNACN culture. When you suspect an infection, that is either the presence of gas in cross-sectional imaging, persistent organ failure, leukocytosis, and persistent fever, or there is organ compression in the form of gastric outlet obstruction, intestinal obstruction, or biliary obstruction. Now, talking of infection, this is a very interesting paper which was an offshoot of a larger randomized trial, the ProPatria trial. Now, the ProPatria trial was a trial which compared probiotics in acute pancreatitis. Now, that was another story, but what it showed is that if you look at infections in acute pancreatitis, so if you look at infections in acute pancreatitis, in the first week, usually all the infections are primarily related to pneumonia and bacteremia. Infected necrosis actually starts coming in sometime between the second to third week. On average, most of the infections happen on around the third to fourth week of illness. So is there a role of antibiotic prophylaxis? This is an often discussed point, but now we know that from multiple randomized control trials, of which have been summarized into systematic reviews and meta-analysis. One is the Cochrane meta-analysis showed that there was no benefit of giving antibiotics to prevent infection and necrosis, no mortality benefit. In a small study which used carbapenems, it has been shown to reduce the infection, peripancreatic infection, without any benefit on mortality. So current guidelines from different societies do not recommend the use of routine antibiotic prophylaxis in either moderately severe or predicted severe acute pancreatitis. So, but then how do we end up diagnosing infection in acute pancreatitis? That is a dilemma that all of us face, because the patient comes in with, after 1 week of illness, has persistent fever, leukocytosis. Do we start antibiotics now, or do we wait, and how long to wait? More often than not, we rely on clinical signs, that is a persistent organ failure, new onset organ failure, or fever with persistent leukocytosis and elevated CRP or inflammatory markers. Now, otherwise, if the imaging shows, cross-sectional imaging shows gas within the collection, or if you can obtain an FNAC. In a study which compared all these three modalities, that is clinical signs, imaging, and FNA, overall, the diagnostic accuracy of infection was similar. Timing of interventions was similar. There was no difference in the mortality when you use either one of these three modalities to diagnose infection. Going on to show that sometimes clinical skills are as good as putting in a needle in a patient, and many a times when you put in a needle, at least 30% can come as negative despite having a false negative. Most of the infections that we encounter are usually monomicrobial. A small percentage are 38% are polymicrobial or fungal. The most common bug that we encounter is E. coli because it's always a gut translocation. And yeast is seen in a subset of patients, or 9% most of these people who have been exposed to prolonged antibiotic therapy. So once we diagnose infection, do we intervene right now or do we wait? So this was addressed in a multi-center superiority study called the Pointer study. The Pointer study evaluated whether postponed drainage, that is after formation of Waldorf necrosis, or do you drain it immediately after the diagnosis of infection. Overall, there was no difference as regards the complications rate, mortality, new onset organ failure, or necrosectomy. However, when you look at the number of interventions, the mean number of interventions were higher in the group who had an immediate drainage. What is more interesting is that 39% of the individuals could be managed with antibiotics alone without having to do any intervention. So just because there is infection, we do not need to stick a needle or take up for surgery immediately. Antibiotics work in a subset of individuals. Now, if you look at the interventions, what are the interventions available? Interventions include open surgical necrosectomy, putting a pigtail drain, video-assisted retroperitoneal drainage, endoscopic drainage, and endoscopic necrosectomy. Now, open surgical necrosectomy was probably what was used for many years until we realized that with the open surgical necrosectomy, there is a risk of prolonged ICU stay because of the surgical stress, and the cost and long-term hospitalizations were higher. So gradually, more and more people have started moving to minimally invasive techniques, and one technique is placement of the pigtail catheters or a Malicot catheter within the infected collection. So once you place this, the bulk of the infection of the fluid drains out, reducing the stress and the inflammatory markers. And when this is not effective, Howard et al. In a study in 2001 showed that you can use the same track to go on and do a video-assisted retroperitoneal drainage, which is a minimally invasive technique to reduce complications and, of course, the mortality associated with a major surgical intervention. So I'll just show you one of the brief videos, if I can play it. Can't control the video. Yeah, it's playing, but I can control. Okay, yeah. So you can see this is a. Oh, I'm not able to run the video here. Can you help me with this? The mouse pointer. No, just anything to control the mouse. Okay. No worries. No worries. So, anyways, so yeah. So you can see this is the collection which has got a lot of gas inside. So what they do is they had placed a percutaneous drain into this, which is the percutaneous drain. And along the percutaneous drain, the tract was dilated further. And once the tract is adequately dilated, the surgeons use a nephroscope to go inside and perform necrosectomy. So how does open surgical necrosectomy compare to minimally invasive necrosectomy? The PANTA study, which was a landmark study, again from the Dutch acute pancreatitis study group, and probably all of our information on pancreatitis actually comes from this group. So this group compared open necrosectomy to minimally invasive techniques, and overall it showed that on the whole mortality is same. However, the risk of major complications is lower in minimally invasive, need for ICU admission is lower, diabetes mellitus is lower, incisional hernia is lower, healthcare utilization costs are lower with minimally invasive techniques. Again, interesting offshoot is that 35% of the patients improve with just placement of a percutaneous drain without requiring necrosectomy. So just placement of a percutaneous drain goes a long way in thing. So what are the predictors of success of PCD is organ failure resolution, reduction in volume of collection after 1 week. Pankaj Gupta from PGI did a very interesting study where he upsized the drain size by 2 to 4 French every 4 to 6 days. It was a very aggressive drainage technique. Every 2 to 4 weeks he went on upsizing it until the entire collection was drained out. And what it shows is that with this technique, there was no increased risk of complication. However, it reduced the rate of hospitalization and ICU stay. So now coming to endoscopic technique, the endoscopic technique is probably very helpful in conditions where the collection is very close to the vicinity of the stomach and duodenum. But in collections such as this, which is going down the left paracolic gutter with a little bit of fluid and all, endoscopic drainage is probably not a very good option here. And if this is the case where you would try to put a percutaneous drain and do it, this is where you will do an endoscopic drainage. Now, there are enough and more videos of this endoscopic drainage, but basically it involves placing of us here, we placed a SIMS, allowing the fluid to drain out, and then followed by placement of a double pictal stent within the stent itself. Sometimes this is not enough, and we have to go on and do a bit of necrosectomy, that is involving dilating the tract, going inside the necrotic cavity using different instruments. There are now dedicated instruments to do necrosectomies, but early on we were using on baskets, snares, Rothnets, etc. to go and clean the cavity. And while doing that, one has to be sure that they don't injure any vessel, because one of the bigger complications is sometimes you get this massive bleed that happens when you're doing an aggressive necrosectomy. So how does endoscopic compare to surgical step-up? Now, we compared surgery to open necrosectomy, now endoscopy to surgical necrosectomy, minimal invasive. Overall, no difference. New onset organ failure, death, bleeding, perforation, exocrine necrosectomy, no difference. However, the rates of pancreatic fistula are higher with the surgical step-up approach, and the length of hospital stay is longer with the surgical step-up approach. So this is where endoscopy scores a point higher than a surgical step-up approach. So now earlier we were using plastic stents for doing the drainage. Now with the advent of these fancy stents, the Axios, Paxos and Nagy, many of us had moved on to doing the metal stent placement in walled-off necrosis. So do you really need a plastic metal stent? This is the latest study, again from this group, which came in 2023. It's called the Axioma trial, a prospective cohort study comparing LAMPS to historical cohort of tension trial. Basically, they compared lumen opposing metal stents versus plastic stent. Overall, no difference. need for an endoscopic necrosectomy, major complication, organ failure, bleeding, perforation, biliary stricture. There was no difference between lamps and plastic stents. So using multiple plastic stents is probably good enough, reduces cost of the entire procedure. So what was the guidelines put forward by the society? So EUS guided drainage is probably recommended for symptomatic one in close vicinity to the stomach and duodenum, should be performed when collections have a well-formed wall. EUS guided is preferred over conventional. Double pictal plastic stents are acceptable safety profile and adequate drainage. Sorry, I'll just move ahead quickly. And symptoms suggest of pancreatic fluid collections after stent placement indicates need for endoscopic necrosectomy. Now, some of the patients are very sick, cannot be mobilized to the theater for a ward or thing. So one thing which we can do at bedside is called stent-assisted percutaneous endoscopic necrosectomy. The tract that was placed for the percutaneous drain is dilated, and then we place in a fully covered esophageal stent, and through that stent we perform endoscopic necrosectomy. So this is what you can see. There's a patient who had a esophageal stent and lamps, and through the lamps we go in to do necrosectomy, and we can take out this much amount of necrosome. So overall the studies are very, very small, very limited in outcomes, but the studies have shown that the technical success of this procedure is very good. However, the clinical success varies between 70 to 80%. So to summarize, for WON, as of current therapy, use endoscopic drainage or percutaneous drain placement, followed by necrosectomy or VARD. And we need a multidisciplinary approach requiring all these people. And with this, I would like to invite you to the upcoming International Association of Pancreatology meeting, Pancreas 2023, in AeroCity on the between 15th to 17th of September. Thank you so much.
Thank you for the nice presentation. Any questions from the audience?
Good morning, sir. What is the risk of bleeding while taking the metal stent after necrosectomy?
You're talking about the lumen opposing metal stents?
Yeah.
The risk of bleeding are similar to that of a plastic stents. However, we have to be cautious to remove them within 2 to 3 weeks of placement of the stent and not keep it for a longer period of time.
Okay, thank you, sir.
Very nice talk.
Thank you, sir.
I have a few observations about presence of gas in the necrotic material. Generally, in most of the time, 99% of the time, if you find gas in the necrotic material, it just means that there is a communication which has already happened. So if you find a gas and patient is improving, it means there is a luminal connection. Most of them spontaneously improve without any intervention. Spontaneously created, the communication drains better than whatever we create. And then about necrosectomy. Generally, most of us pick up all the necrotic material which are lying down in the cavity. We actually don't do the necrosectomy the way the surgeons does it. They remove attached tissue. Our job is to create enough lumen when these necrotic material becomes smaller and it drains out easily. Most of the time, these stents get blocked by these fallen necrotic material, and that is a cause for worsening of patient. And that happens more often in percutaneous drainage. So if you had done a MRI before doing a percutaneous drainage, if you haven't seen much solid necrotic material in that, then simple drainage and small upsizing will work. If I find lot of solid material, generally we dilate the tract using, most of the time I use Savrigila dilator to 13 millimeter, and then use our adult endoscope. I find I've used a lot of accessories for removing these necrotic material. There are setbacks for using Rothnet. You can cast the necrotic material, but then you cannot release it
easily
within the stomach. So
Yes,
we
sir.
need to take the scope out. So I find snare very useful. In fact, if you can find a snare which has a solid, the proximal end, just like a lithotripter, then you can cut it into small pieces and leave it. It will work out well. Thank you.
Thanks, sir.
I have one doubt. So if we have a patient with acute necrotic collection for whom we clinically suspect to have infection due to fever, leukocytosis, and then we have a collection documented which doesn't have air pocket. So we go ahead with the pigtail drain. At the same time, we start the patient on carbapenem also. This is what practically happens for most of the patient. And then collection culture turns out to be negative. And after pigtail, patient becomes all right over next 3 to 5 days. When do we stop antibiotic? When do we remove this pigtail? Pigtail keeps on draining 200-300 ml per day. So these two questions are practically difficult to answer.
So the first answer to the first question, when do you start? Once you start an antibiotic, I would actually give it for a good entire course of 2 weeks. Definitely I'll continue the antibiotic for 2 weeks. Beyond 2 weeks, I think it really doesn't matter. And as regards the drainage, ideally we would take it out only when the drain output is less than 20 mils. If the drain output is more than 20 mils, if you pull it out, it will again form a collection out there. So if the drain output is at least up to below 20 mils, only we will take out the drain.
So do you discharge such patient with pigtail in
Yes.
situ home?
Yes. No need to keep them in hospital, as if the SRS is settled, best is to discharge them. What we do is many a times we put a colostomy bag on the wound and let it be. So the person also doesn't go around walking around it, and they come and show how much is collecting every day in the colostomy bag. And that is a very good metric to judge.
When do you intervene with the PD stent for such patients who continue to drain? Is there
I
any time
ideally
interval?
do not try to do any PD interventions. I didn't touch upon disconnected pancreatic duct, but I think if you intervene early, you will definitely see a leak. If you intervene a bit late, by the time the leak will settle. So most often than not, I prefer not to do any pancreatic duct stenting in this group of individuals.
Like cystogastrostomy, we generally don't do before 4 weeks. After 4 weeks, only wall matures. Some data is there. Is there anything like PD stent should be considered after so many days of continuous pigtail?
No, I don't think so. There is much data, but if there is a documented leak and a high-end fistula which is persisting beyond maybe 2 to 3 months, we definitely do a good MRCP to see the leak. At this point, maybe we'll consider doing a PD sphincterotomy and stenting. The stenting is just a bridge, but ideally I will not try to do a bridge of the fistula also. Just a sphincterotomy, that's good enough to take care of it.
Thank you.
Thanks.
Last question, please.
Yes, sir. Nice presentation, sir.
Thank you.
Initially, we are taught that depends on the percentage of necrosis in that it's a selection of stent, whether the plastic stent or the metal stent, like 30% necrosis, then more than 30% you go with the lamps, it will be better. Re-interventions are less like. And latest you told that the multiple plastic stents serves the same purpose. So that one question. The another thing is that one interesting study you told upsizing every 2 to 3 days with catheters. Why can't we put straightly a bigger size catheter in the first sitting itself? That will solve the problem.
So I'll answer the first question. As regards lamps versus plastic stents, you are correct. Till a point of time, we were all looking at the 30% as the holy grail to decide between which one you do. But actually, after speaking to surgeons, all of us have realized that actually you don't need to do the necrosectomy. The necrosis is not the problem. It's the pent-up infected fluid inside which is creating the SIRS features. So in this group of individuals, if you just take out the fluid, that will usually take care of the thing. Now, why we were putting lamps was an easy access to go and do a necrosectomy. And probably you don't need to do an aggressive necrosectomy in all the group of individuals. As sir was alluding to, I remember that, I had an Ethiopian surgeon standing behind me when I was doing a necrosectomy. After 1 hour, he looked at me irritated and told me, "What are you doing?" I told gallantly, "I'm doing necrosectomy." He said, "These are things I leave behind. You don't even need to take this out. Why are you wasting your time and my time by doing these things?" So basically, aggressive necrosectomy is probably not required. Just take out the muck. That is good enough. Coming back to the second question as regards why we don't upsize as the first instance, I leave it to our radiologist to decide. But I've realized most of the radiologists feel very comfortable putting a 14 French drainage at the beginning, and it's very difficult to convince them to upsize actually. But when you can convince them, they gradually go up to 28 French. But it's very difficult for them to do a thing at the first instance. Thank you. Thank you.
Thank you, sir. Next, I call upon Dr. T.S. Chandrasekhar
who's a well-renowned interventional endoscopist and gastroenterologist who has many credentials on his side. He's going to discuss on how to tackle difficult CBD stones.
Thank you, dear chairpersons and Dr. Avadi, for your kind words. And I must congratulate the organizers for this wonderful academy feast to our Tamil Nadu ISD members. And it's a privilege to be a faculty in the Tamil Nadu ISD state chapter. My topic is a difficult one, because the title itself difficult. The difficult CBD stone. I want to tell you some of the few tips, tools and tricks. I see a lot of postgraduates are here. I was wondering, there has to be some difficulty here.
How do you tackle this?
You call the organizers and remain cool and get extra time.
For the procedure?
No, for the slide presentation. Don't do it. And I was wondering why this topic. It is a time immemorial. Ever since I joined DM postgraduate, I've been talking on CBD stones. So this topic again given to me, I was just wondering why. Because this is the bread and butter. Okay. You go ahead. Okay, thank you. This is the bread and butter. So my job is to serve the old wine in the new bottle. Okay? Don't calculate this time taken by you. And this is some of the collections we had. This is one thing will tell you that how the stones can complicate. And you'll be really surprised to see the kind of presentation we have there. And if you want to need a little animation, the stone can be over a diverticulum, stone can be the Merge syndrome, or the whole CBD is packed to the stone. Or the stone may be the size of the CBD, there is no room to play around. Or there can be a stone at the ampulla with a severe congestion, and wherever you touch, the bleeding will be there. And type 4 Merge syndrome. This all of you are very familiar with the Merge syndrome. And type 1, 2, 3, 4. And the 4 is the most difficult one sometimes. And there is a data available. And when the stone size increases beyond 2 centimeters, the success rate also comes down. That means you need to have the higher end procedure, or you need to have the technology and techniques and the tools. And the further data you recall from the surgical endoscopy, I think my colleague surgeons would agree that if it is more than 25 millimeter and the 30 to 40% only we can remove through endoscopy, and the rest had surgery, the stenting or some kind of dissolution. Nowadays we don't go for the dissolution. It has been now given up now. Now this one slide will tell you why difficulty. Stones more than the size of 2 centimeters, the shape of the stone. If it is more organized, rectangular, it will be hard. If you see calcium, you see in the fluoroscopy, calcified stone means very difficult to crack it. And the stone and stricture, always you mind that the lower CBD anatomy. The narrower the stricture, narrower the lower CBD, more difficult will be there. And type 3 Merge syndrome, where partly neither here nor there, and both the places very difficult to handle it. And the 4th and stone fully occupying the CBD, there is no space to room the play around, and impacted CBD, there will be congestion due to the bleeding, and multiple intrahepatic stones with the strictures. Now, having summarized why difficulty, even though there is no general consensus, whatever difficult for the endoscopy, I agree with you, this is a difficult CBD stone. 3 major categories. Stone characteristics, I told you already, and anatomical variation. Periampullary diverticulum, or you have a ruined by gastric bypass, Billroth 2 anatomy, bile duct stricture, and the patient general condition. We will not take out this now. Bleeding diathesis or compromised heart and lung conditions, and age is more than. Now, what are the tools we have? If you don't concentrate on the tool, you will cut a sorry figure here. Now the basket is impacted. What I'm doing is sacrificing the basket. This is one of the old video. And I was thanking my guru, that Dr. Sohendra. I've seen him doing this procedure in Hamburg when I was a fellow there, how he was doing it. So we had to repeat this kind of thing and use the Sohendra lithotripter. If you want to avoid this kind of situation in your practice, you have to concentrate on the tools and technology. And never ever do a procedure without having this Sohendra lithotripter. That will be life-saving. Otherwise, with the scope in situ, you have to take the patient to the theater and ask your surgeon, and he should be available. And you have to save the scope, save the basket, and save the patient, and save your reputation. And the tools, extractor balloon, Dormia basket, then is balloon sphincteroplasty, spyglass. The one tool has really made a lot of difference and made a little more enmity with the surgeon is spyglass. We hardly ever, the last 100 cases I have seen, hardly ever we have referred the patient to my surgical colleague. They are also happy because they are busy with other cases now. And mechanical lithotripter and the laser. The one another equipment that really made difference is and we use the holmium laser lithotripter. It's fantastic equipment. I think and extracorporeal Schaukel lithotripsy no longer we use it in a very, very rare situation, very frail patient there. We can't do anything other than this, means you have to take it. And finally, we rely on laparoscopy CBD exploration. And you need to have the experience and the evidence-based approach for managing the CBD stone. And the experience guide sometimes it takes over. The first question I'll ask my colleagues is, what is the lower CBD anatomy? Is there calcium in the stone? What is the shape of the stone? What is the size of the stone? And leave alone, apart from that, general comorbidity. Once I had to burn my finger that one doctor was referring a patient, I'm referring a CBD stone. How much it will cost? Generally we said 40,000, 30,000. And the moment I saw the patient, he had a cardiac risk, pulmonary risk, and a lower CBD stricture, and a 2.5 centimeter stone. And now the patient insisting I can pay only this much. So, and lower CBD stricture, I had to use the lithotripter, I had to use a spyglass, and laser lithotripsy, everything. So when you plan your thing, leave alone the cost, the safety of the patient, very important. You must take into the account all these things very important. And there are several tricks. I want to tell you here, a lot of postgraduate. The tricks is exploit the power of leverage. Archimedes said, give me a lever long enough and a fulcrum to place it, I shall move the world. So how it is now? If you pull it, hard work, nothing works. If you have a smart work, success is there with you. What does it mean here is, you pull it along the axis of the CBD, then along the axis of the common bile duct. If it is less than that, then you are going to not be successful, and you pull it like this and pull it like this. This is how the stone come up to the ampulla after the traction along the CBD. This is a nice animation to explain how we have to change our most of the movements in the scope. And these maneuvers need to be exercised either one by one or one after another simultaneously. And this video is going to tell you very, very clearly, if you have not learned this technique, then you will not be successful in and pull the basket towards the ampulla, axis across the CBD axis, stone moved up to the CBD. Now bigger wheel down for CBD axis alignment, stone moved up to the ampulla. Very important second step. Smaller wheel to the right, and that is towards the duodenal axis. Stone is dragged in towards the duodenal lumen. Now push the duodenal scope down. And I've seen very swift management of fast or simultaneous management, all the four, and the stone is delivered into the duodenum. If it is not there, it will be struggling, and don't pull it like what you do it in the temple card. So it is not going to happen like that. So this is what bigger will down, smaller will to the right, push the scope down, and this is what it is there. And I'm just showing the video. This is how it is being done. And you practice, and simultaneously. The moment you touch the scope, you forget all the movements because you have not practiced enough. Now you see this how the movements, and this is what the trick is very important in delivering the stone. If you have a diverticulum, you have the mini biopsy forces called maximini. Then you identify the ample of water and you cannulate. And it's a fantastic technique that you have to master it. You have to handle it in such a way that both the biopsy forceps and the cannula, guide wire, and you see the CBD, this is what it happened, ampullary diverticulum. Tools with the tricks. You have to be thorough with the knowledge about this. The mechanical lithotripter, if it is less than 2 centimeters, success rate, and more than 3 centimeters, the success rate is 3%. Now, mechanical lithotripsy is not very cost effective unless you handle it very, very, very carefully. Now, the came to rescue is the balloon sphincteroplasty. It's a fantastic technique. There are data are available after the advent of sphincteroplasty. The need for mechanical lithotripter has come down. So I will show you the data here now. This is you do a almost near full sphincterotomy. If you do partial sphincterotomy, you are likely to get pancreatitis because of the balloon dilatation. I will not go into the details of the balloon dilatation, how many seconds and 30 seconds, 40 seconds size of the balloon. Itself a big topic, but what a wonderful technique. The only major contraindication is the long lower CBD stricture. Do these maneuvers. And don't forget the maneuvers, bigger wheel, smaller wheel, and turning the body towards the right. Why I am insisting so much is the body movements and the wheel movement is so vital, without which you can't do that. So there are data available with the sphincterotomy alone and the balloon sphincteroplasty if you do that. And make sure that your stone is not caught between the balloon and the stone. Then you may end up in problem. Make sure that bring the stone down and the sphincteroplasty is being done. So these are the very practical points I just want to tell you that. And never ever dilate the lower CBD beyond the size of the upper CBD or mid CBD. Again, another, you are likely to get into perforation. And the data saying that sphincterotomy, no sphincterotomy, pancreatitis, minimal sphincterotomy, so moderate and full size, near full size you can go there. Maybe in elderly people will do the moderate sphincterotomy followed by balloon dilatation. And the review article came in 2014, endoscopy says, in a large CBD stone, a systematic review and meta-analysis, it reduces the need for mechanical lithotripter and cost effective also. I will not make you to concentrate on this because it may take time, but take it from me that balloon dilatation has come and has really done wonders. If it is more than 2.5 centimeters, straight away go for the large balloon dilatation. This is one. And a spyglass, wonderful. After the single operator, and I started my career with the mother baby, then it became a single operator, and this is fantastic technique, not only for indeterminate biliary stricture, large CBD stone, holmium lithotripsy. I do not use an electrohydraulic lithotripsy, but this is wonderful, and 20 watts will do that. And just a video showing that. To start with, you can have a 2 operator also. After that, you are so proficient, you can do that. But there is no hard and fast rule. That has to be only single operator and lithotripter. My stone is not yet delivered. Can I borrow 1 minute? Yeah. So this is the stone. This is the sphincterotomy done. And referred, then I'm extending my sphincterotomy and see the large CBD stone and sphincterotomy being done. And laser lithotripsy, and this is what it is now. Extracorporeal lithotripsy, I hardly ever refer it. The very frail patient, I put a stent and by time, and this is what it is. And the extracorporeal, there are data available, but this is before the advent of the spyglass. And when nothing works, patient is very bad, cholangitis, elderly, 97 years comes. And he will also threaten you, and your BP also will go up, and you will. So what you do is just place the stenting for large CBD stone. You call them after 3 months. Whole thing is total scenario is changing, and now the stone can become little softer and smaller, and there are enough data are available and stenting. So when you can't do that in a peripheral unit where you don't have everything augmented, at least put a stent by the time, save the patient from cholangitis, and this is what it is. And it is indication elderly comorbidity and prevent stone enlargement, and the plastic stenting can be done. And the data is from digestive endoscopy 2009. Which is a better tool? Balloon extraction is better than sphincterotomy. Mechanical lithotripsy is better than balloon extraction. Sphincteroplasty is better than mechanical lithotripsy. And spyglass, larger the stone, more difficult. Spyglass is and laser lithotripsy the best actually. Sometimes in a single case, you may have to use all the armamentarium. You have to be an expert in this one. So ladies and gentlemen, medium to large CBD stone, mechanical lithotripsy, very large stone, coagulopathy, we will have the balloon dilatation and do that. And very large CBD stone above the stricture, very hard stone, type 3 Mirzi, I go for the spyglass. And altered anatomy, there are various ways of doing it, US guided. Now EDGE has come, ERCP directed, and the pancreatoscopy has come. When nothing works out, then you have to go for the stenting. Altered anatomy, I am not covering this, and double pigtail stent. So finally, to conclude here is, assess the stone size properly, choose the appropriate modality. Baskets most cost effective, wire guided baskets are for intrahepatic stones. Balloon CBD with a single or multiple stones, soft stone, mechanical lithotripsy, I have defined it, sphincteroplasty, and spyglass and stenting. And the key is the appropriate tools and tricks. And with this, I thank you very much for this wonderful opportunity given to me.
Thank you, sir, for the fantastic presentation. I have a question. If there is a large periampullary diverticulum, what precaution you take in doing balloon sphincteroplasty? You do or you?
That's a very good question. If it's a large periampular diverticulum, the moment you make everything, you know that, and don't blow too much of air, don't apply suction, the first cannulation should be very successful. And the moment the peristalsis comes in, then there will be hindrance for cannulation, number one. Number two, do not do the full sphincterotomy because stones will easily come out unless there is going to be a stricture. So I would do the best cannulation the first time itself without proper excessive suction, number one. Number two, I do not do the full sphincteroplasty. And change of axis, you have to know that. If you see the MRC picture, the axis, how it is come, accordingly you change your direction of the scope and near moderate sphincterotomy and deliver the stone. The best bet is the balloon is a better one because it takes this course of the deviation of the common bile duct anatomy and you can deliver the stone. And elderly patient, more important is do not do the full sphincterotomy. And you can anticipate bleeding. Keep yourself ready with the noradrenaline, other parameters.
Thank you, sir. Any questions from the audience?
So, very nice, complete coverage of stone management. Many of big stones will be easy for you. It may not be the same level of difficulty for junior. In one of your cartoon, you mentioned that you cannot dilate the lower CBD larger than the proximal duct. But if the proximal duct is 18 millimeter and the lower CBD for a length of say 4 centimeter, it's only 3 millimeter in diameter, how will we be able to dilate to that size? Will it not cause bile duct
That's a nice practical question. I appreciate Ravi. If the longer the stricture, more than 1 centimeter, sphincteroplasty can complicate with the perforation. I am telling the shorter the stricture or no stricture, there is something. and do not dilate it beyond the proximal diameter, because then chance of perforation is high. That's what I meant it. I mean, everyone has delivered the difficult CBD stone. No questions, I think. Thank you.
Thank you very much, sir. The next topic is Clostridium difficile infection. And I request Dr. Bharat Kumar to enlighten about us.
குட் மார்னிங். இரும்பு அடிக்கிற இடத்துல ஈக்கு என்ன வேலை மாதிரி 2 இன்டர்வென்ஷன் லெக்சருக்கு நடுவில் கிளாஸ்ட்ரிடியம் டிஃப்சீல். ஐ எம் சாரி, இட்ஸ் கர்ட்ஸி பிகாஸ் ஆஃப் டாக்டர் உபால். ஸோ Clostridium difficile has become Clostridioides difficile now, and it is becoming a huge burden. As we all can see, 10 to 25% of antibiotic-associated diarrhea is because of C. diff, 15 to 75% of colitis, 90 to 100% of pseudomonas colitis is because of C. diff. And the mortality rate has increased, and it has surpassed MRSA as a most common hospital-acquired infection. And India is not far behind, India being the largest user of antibiotics, and we don't have any regulations with the usage of antibiotics. The prevalence rate is somewhere between 1.2 to 29%, but we don't have proper prevalence studies because this is a bias due in the tertiary care hospitals. What is Clostridioides difficile? It's a gram-negative anaerobic spore-forming toxigenic bacteria, and to say as a Clostridium difficile infection, there should be 3 or more unformed stools in less than 24 hours, and there should be a positive stool test to identify either the organism or the toxin. And there is no need to test for a cure because the patients can keep shed the spores and stools for more than 6 weeks. And pathogenesis, as we all know, exposure to antibiotics causes dysbiosis. There's something called as colonization resistance, which is normal bacterial flora resisting the colonization to C. diff. And that results in, if there is a disruption in the normal intestinal flora, there is C. diff colonization, and C. diff, as we all know, produces 2 toxins. The cytotoxic toxin, cytotoxin B. Toxin B is the one which is primarily responsible for causing the infection. And that results in destruction of intestinal epithelium. And how do we go about testing for C. diff? We have to identify the organism and we have to identify the toxin. And we need to do this in a 2-step approach because we have to differentiate between colonization and an infection. But just identifying the organism alone might not be enough because as we said, we have lots of colonizers and lots of carriers, so who might not actually be having the disease. So ideally, a 2-step approach is done. What are the tests which are being used? There are gold standard tests and the tests which are conventionally being used. The gold standard test to identify the organism is toxigenic culture, and the test to identify the toxin is cytotoxic assays. But they are all time consuming. They need facilities and infrastructure for culture growth and doing the assays. So not being very practical, being used in conditions to identify the strains in an outbreak. But what are the tests which are being used nowadays, which is our conventional ELISA tests and nucleic acid amplification tests. The ELISA test to identify GDH, which is glutamate dehydrogenase, which is a component of C. diff. But the downside of this test is that it is positive in all the colonizers, so it might not be picking up the infection, so it's necessary to identify, do another test to identify the toxin as well. The same is applicable with the RT-PCR, which is extremely sensitive, and even a very, very tiny dose of the bacteria can result in positive results. So to identify an infection, we have to do one more test to pick up the toxin. So a 2-step approach is the ideal one. So if there is a simple rule, no symptoms, no testing. The patient is not having any loose stools, do not test for C. diff. If the patient is presenting with just symptoms like that of a C. diff infection, then we do a test, an initial test to identify the organism, which is a GDH test or an RT-PCR for an NAT test. If it is negative, C. diff infection is excluded. But if there is a positive result, then we have to differentiate between a colonizer and an infection. So we go ahead to do an ELISA test to do for the toxin. And if the toxin test also comes as positive, then we have a C. diff infection. If it is negative, then there are three possibilities. One, the toxin levels are very low for detection, or it's a false negative result, or we are dealing with a carrier state. How do we classify C. diff infection? Mild to moderate, severe, and fulminant. Mild to moderate, where there are present symptoms, no other signs of invasive infection in the form of leukocytosis or an elevation in the serum creatinine. Severe, we call when there is a leukocytosis, more than 15,000 white cell count and creatinine more than 1.5 of the baseline. And very severe or fulminant, we have other signs of peritonitis in the form of sepsis and multi-organ dysfunction with toxic myocolon and other signs of colonic dysfunction. Recurrent, wherein there is symptoms less than 8 weeks after completing the treatment, and that's quite common in persons with C. diff infection. So how do we treat? The treatment algorithm goes on to say if there is no symptoms, no testing and no treatment required. But if the person is having symptoms, mild, moderate or severe, mild to moderate is usually treated with vancomycin or metronidazole. Metronidazole 500 mg 3 times daily for 10 to 14 days. Vancomycin, oral vancomycin 125 milligrams 4 times a day for 10 to 14 days. Whereas in severe cases or fulminant cases, we go ahead with treating with high dose of oral vancomycin, which is 500 milligrams, along with IV metronidazole as well. Going on, highlighting fulminant C. diff, less than 10% of the patients present as a fulminant infection, and diarrhea is minimal due to abdominal pain and peritoneal signs. Marked sepsis, leukocytosis, and multi-organ dysfunction will be there. Preferably, if always aim to stop the non-diff antibiotics, but in most of the patients, there will be an ICU setup requiring other various antibiotics being treated for pneumonia or complicated urosepsis. Then we preferably use up antibiotics which don't predominantly cause C. diff. And high-dose oral vancomycin 500 mg QID plus IV metronidazole is the first choice. Vancomycin via NG tube and along with intermittent clapping is also tried. Vancomycin enemas in the form of 500 mg and 100 ml of normal saline also being given. Salvage therapy, IV tigecycline, 100 mg loading dose followed by 50 mg PID. And if things are not improving, you are looking at a total colectomy with loop ileostomy. Special scenarios, IBD and C. diff, slight difference in the presence of IBD, C. diff presenting in IBD. Usually, there is not much of an antibiotic exposure in persons with IBD. That is quite commonly community acquired. So, in anyone with IBD presenting as a flare, it is important to test for C. diff and to treat them accordingly. Differentiating persons with IBD and non-IBD. Non-IBD persons are generally older age, antibiotic exposure is usually there, and more often it's hospital acquired. Whereas in IBD patients, they are younger, antibiotic exposure is less likely, and more often is community acquired. And the rate of recurrence of C. diff in IBD patients is quite high because of persistent dysbiosis happening in IBD patients, whereas the rate of recurrence in non-IBD patients is less. Treatment is very similar to the lines of how we treat a normal C. diff. Uncomplicated C. diff, vancomycin, and improvement in 3 to 4 days, continue for 10 days, and treat with, if not recurrent, if not getting better, treat once again with tapering dose of vancomycin, and recurrence is very frequent, then we try FMT. The important role here is where we need to consider the usage of immunosuppression, preferably to avoid escalating immunosuppression during a C. diff infection as well. Recurrence, diarrhea within 8 weeks of completion of treatment, But 35% of the patients following treatment tends to present with transient symptoms for at least 2 weeks of functional symptoms, then up to 43% present with post-infectious irritable bowel. But the two-step approach, identifying the organism and identifying the toxin, is mandated to make sure we have got C. diff or it's just a IBS. And standard therapy is what is used for treating recurrence. Prolonged antibiotic regimens been tried. Sequential therapy with vancomycin and rifaximin and intestinal microbial transplant. Immunization against C. diff and Clostridium difficile vaccines are also on the trial. Where shit matters, so at least in some places wherein things have been found to be useful, but FMT is not yet an approved treatment strategy, but has been noted to have a cure rate in more than 90%. When do we contemplate FMT? More than 3 episodes of mild to moderate CDI and failure with taper dose of vancomycin. More than 2 episodes of severe CDI requiring hospitalization. Those are 2 straightforward indications where FMT has been tried, but can be considered on an ongoing progressive illness as well if there is a moderate CDI not improving with 7 days of vancomycin treatment and severe CDI not improving within 48 hours of standard treatment. Risk factors: increasing age, PPI usage, prolonged antibiotic, long stay in hospital, and decreased antitoxin levels are the common causes or factors for recurrent CDI. Don't test asymptomatic patients. 2-test approach is always preferable. Identify the organism and identify the toxin. Differentiate between colonization and infection. Try to stop non-diff antibiotics. No need to test for cure. Always test for C. diff and IBD flare, and oral use of vancomycin. Oral vancomycin over metronidazole is the preferred choice. Preventive measures like hand wash, better than alcohol gel, patient isolation, and environmental cleaning have all been found to be very helpful. Thank you.
Thank you, Bharat, for the very nice and crisp presentation. And any questions from the audience? Yes.
Nice presentation, Bharat.
Thanks.
So, in your practice, how do you go about diagnosing C. diff? You first do a PCR or a GDH before doing a toxin assay? That's the first question. And what are the drugs, the newer drugs available currently in India?
Fluoxamicin is not available in India, so that's why I have not touched on that. What do we do in our practice? We commonly test for C. diff toxin. Even though the sensitivity levels are less, we actually don't do the 2-step approach in practice. But actually, because of cost cutting. We straight away do the C. diff toxin. If it is positive, we treat it. The downside of it is, it's not a very sensitive test. It might not pick up the toxin assays quite well. But nowadays, our ID people are asking for RT-PCR and the toxins. So when we involve the ID, they always check for PCR and toxin tests, which is coming into. We are putting into practice this.
Is there a role for empirical treatment? There is, I mean, without testing, can we give a trial of metronidazole in such patients and see for the response?
No. No.
Okay, thank you.
That was a very informative talk, sir.
Thank you.
I have one question about fecal transplant. So, in recurrent clot diff, we know that it is, even though it's not completely proven, but these are immunosuppressed patients, even IBD.
In IBD, yeah.
In IBD or even other conditions.
See, when I read about the FMTs, FMT is a contraindicated option in persons with significant immunosuppression, but being tried with in IBD and they are found to be quite useful. Other causes, other conditions wherein there is significant like post-chemotherapy or post-significant immunosuppressive options, FMTs have not been tried. In IBD, it has been tried and is found to be useful.
Should we do it
but
between
they
the
are
two?
advising us not to escalate immunosuppression during FMT.
But during immunosuppression, at least with the standard biologics or with azathioprine,
they are asking us to continue. It has to be individualized and it has to be tailor-made for the person. There is no strict guidelines.
Included.
Yes.
Everything. Thank you. Thank you.
Thank you for the nice presentation.
Thank you very much, sir.
Thank you, Chair Speakers and the Speaker. We shall now adjourn for a short tea break. I request all the delegates to come back for the session by 11:15, please.
Good morning to all of you. I think now we have reached the most important event of this conference. That's Professor N. Madanagopalan oration. Briefly speaking about Professor Madanagopalan, in fact, I have not really seen him or worked under him as a gastroenterologist, but he was one of the most, he is a person who created one of the greatest inspiration to all medical students in general with his excellent work. He had a major passion to develop gastroenterology in Tamil Nadu, and he is the doyen of gastroenterology in Tamil Nadu, having worked for many years in Madras Medical College, and then moved on to create a separate Institute of Digestive Disease Center at Chennai. He's been an incisive thinker, a great clinician and a great teacher, and probably the person who did some of the best clinical research in gastroenterology. In fact, our professor, Dr. Mathan, once narrated how he went to Neyveli and picked up why there were so many patients coming with hepatocellular carcinoma, because they were churning groundnut oil followed by the seeds of the cashew nut. And the cashew nut oil contained argemone, which was pouring HCC. And this was an on-field work, and it was told to us by our Professor Mathan in our rounds at Vellore. And he's been a great contributor to the MEBSS and Bud Chiari, and he's been a very incisive thinker. I got to see him probably only once when I was in Stanley Middle College, when he came for a symposium along with other doyen, Dr. P.C. Rajaram, who was a professor of radiology at that time. So, without wasting time, we'll move on to this prestigious oration.
Thank you, Venkat. So may I invite the persons selected by the Tamil Nadu ISG for this year to deliver the Professor Madanagopalan oration, Dr. Murali, and while he comes up, before we start, sir, we'll just get the medallion. It's my privilege to say a few words about Dr. Murali to this audience who does need no introduction to him. Dr. Murali is a very respected clinician and a teacher. He retired as the Director of Medical Gastroenterology Department at Madras Medical College and currently is heading the Department of Gastroenterology at Miyot Hospital. So I think he's a very apt person to deliver the oration for this year. So may I invite Sir to give his lecture. Dr. Murali, please.
Mic konja adjust pannu. Mic. Idana. Very good morning to everybody. Very good morning to my teachers, senior professors, colleagues, postgraduates, ladies and gentlemen. At the outset, I thank Dr. R. Ravi, Secretary of the Tamil Nadu Tnisgcon 2023, and Dr. Ubal Das, Secretary of the Tamil Nadu chapter of ISG, for giving me the opportunity to deliver Professor N. Madanagopalan oration in front of this august audience this morning. I am very much delighted and honored to deliver Professor NMG's oration, as he was the main reason for me to take up this specialty as my career. For people who doesn't know, I want to tell a few things. I was accidentally posted in medical gastroenterology in 1989 after completing my 1-year compulsory rural service. And I have been posted because there is no vacancy in the medicine, so I was posted in medical gastroenterology. But my main interest was to pursue cardiology. In fact, I even got the prize in clinical cardiology during my MBBS career. I was very trained by Professor Sivarajan also when I was in Stanley, and my only interest was cardiology and nothing else. But after being posted in medical gastroenterology in 1989 as a temporary measure, I was slowly getting attracted to the specialty when I started attending the gastroenterology radiology lectures, which used to occur in every week, and also listening to Dr. NMG's lecture. And thus, this changed my total career. The other factors which influenced my taking up gastroenterology is Dr. K. Raghuram, who was my teacher during my DM course, and he taught us the basics of gastroenterology, and also he supported us during our entire DM course. And Dr. Chandrasekhar played a major role in me taking up the career because he was there as assistant professor at that time, and seeing his skills in endoscopy, I was slowly attracted towards gastroenterology, and he persuaded me to change my interest from cardiology to gastroenterology because that is a upgrowing field at that time. And now we have seen that the gastroenterology has gone to sky high in both endoscopic procedures and a lot of new innovations. And I owe to Dr. Chandrasekhar for shaping my career. The other person is Dr. Dinakaran, who is the brother of Professor NMG. He, along with Dr. TSC, persuaded me to gastroenterology, and he is also our very close family friend. And his daughter and my daughter studied together in school, and we were very close. And it is he who introduced me to Professor KRP, and my life has changed. And he introduced me to Professor KRP when I finished my post-graduation and awaiting for postings in medical gastroenterology. And one day, Professor Dinakaran, the early morning, took me to KRP's home and asked me that I'm interested to work under him. And that's how I joined Stanley Medical College. And I was fortunate to work with Professor KRP. I am in no doubt that he is a role model as how a professor and HOD should function. I have learned a lot from him, which includes the endoscopy skills and the administrative skills. And this was very useful in shaping my career, both as a consultant and later as a HOD. And I learned how he is calm and composed even in critical situations, and how he handles the patients, patient attenders, and colleagues. He never introduced his assistants to a new person as his assistant. He usually introduced them as his colleagues, and he never say, we are all assistant to him. That is a very nice nature of Professor KRP. And I am very grateful to all the people who changed my career, Professor NMG, Dr. Raghuram, Dr. TSA especially, Dr. Dinakaran, and Professor KRP for shaping my career in gastroenterology profession. And now we'll go to the proper lecture. And this topic I have chosen because this is the interest of Professor NMG also. And I was also part of NMG in his trial on philanthropist Nururi in treating chronic hepatitis. I was not his direct student. I was student in MMC when he moved over to DDH Annanagar. But for short course, when there were there were less of manpower in Annanagar, I was asked to help Professor NMG in the OP for 2 weeks during my DM career. At that time, I presented a lot of cases to him, and that is also one of the reasons I took up gastroenterology. Later, after finishing my post-graduation, he was kind enough to ask me to look after his cases which he get admitted in private hospitals. He was called as an expert consultant, and in fact, he has given me the freedom to look after his cases, and he used to visit his patients once in 3 or 4 days. The rest of the time, I was able to look after this patient, and he has given me the great opportunity to work under a good clinician and good teacher. And I'm very indebted to him for giving me a chance to work as a co-consultant in my private practice. And the first case that we treated that in private practice is a very severe acute hepatitis with the bilirubin going from 5 to 40. I can never remember that patient because he had a very severe acute hepatitis. We thought he will go for a acute liver failure. Luckily, he improved, and he was none else than the IDBA chairman at that time. And that is how our relationship, after my post-graduation, after my finishing my post-graduation, I continued to be in contact with him, and I had the privilege of looking after his patients who were admitted in South Madras. I am greatly indebted to him, and I am honored that he believed in me to look after his cases. And now, since it is his interest and also my interest, I took this topic and how to treat hepatitis B, the current concepts, and the Indian perspective. I'm not going to tell all the basic details, which have been excellently told by Dr. Joy yesterday. I'm just keeping upon the latest current concept, more on guidelines, how practically we treat the patients in Indian scenario. So we know that the prevalence of chronic hepatitis B in general population in India is about 1.4 to 2.7. So I have put some alphabets in all the sentences which I have written. This indicates the level of recommendations. You can interpret like that. The predominant mode of transmission of HPV, we know it's more horizontal, but we see vertical transmission also in India. And of the genotypes of common in hepatitis B in India are genotypes A and D. And first we'll come to the prevention of hepatitis B infection through vaccination. So universal recommendation is all infants and the first dose should be given as soon as possible after birth. Second thing is also indicated in people who are with risk factors acquiring infection, those who are dealing with blood and blood products, dialysis patient, solid organ transplantation patient, drug abusers, and household and sexual contacts of people with HPV infection, multiple sex partners, people with and healthcare workers, and others who are exposed to blood and blood products. It has been recommended to have vaccination. Vaccination is advisable for all children and adults who are not previously vaccinated. There is now no evidence to support that the booster vaccination is necessary. Primary vaccination is enough, but in case of necessary, you can always repeat the anti-HBs titer, and if it's very low, we can give a booster vaccination. Otherwise, in general, there is no evidence to support the need for a booster vaccination. For immunosuppressed population, higher doses or increased number of doses are required. The anti-HBs response of these patients should be tested after they are vaccinated, and those who have not responded should be vaccinated with additional 1 to 3 doses. Now we come to how to diagnose and initial evaluation of patient with chronic hepatitis B. During initial evaluation of HPCG positive patient, we must emphasize how they acquired the infection, what is the current phase of the infection, how to stage the disease, and whether there's a need for antiviral treatment, and whether there are additional comorbidities that the patient is having, and more importantly, the co-infection, whether they have associated hepatitis C or whether they have associated HIV infection, and whether there is any family history of cirrhosis and liver cancer. Because these factors are important to decide about whether the concerned person is required antiviral treatment or not. And all the laboratory tests include the complete liver function test, as you know everybody, including the prothrombin time, complete blood count, and markers of viral HPV replication, that is E antigen and HPV DNA, and you have to exclude the co-infection like HIV and HCV. And ultrasound is paramount important, is recommended in all patients. Till we have got controversies regarding what is the normal SGPT in Indian population, till more data are available. LFT of 40 or less than 40 should be considered as normal in Indian parents. Though there are many reports to say to take 19 as the normal for female and 30 or for male, but still in Indian, as per the INASL guidelines, ALT of 40 and below is has to be normal, and for practical purpose, we'll take this as the limit factors for ALT levels. A liver biopsy or non-invasive test should be performed to determine the disease stage and the need for antiviral treatment in case biochemical test and ultrasonography reveal inconclusive results. We also know that even when the liver function is normal and ultrasound is normal, on liver biopsy, we may see a necroinflammatory inflammation and fibrosis. And now, thanks to the advent of the fibroscan, we are able to find out the amount of fibrosis as a non-invasive procedure to detect cirrhosis and fibrosis. And abstinence from alcohol and smoking should be strongly advised for patients during initial evaluation of patient with chronic HPV infection. The barrier method of contraception is advised for patient with HPV infection and detectable HPV DNA if the partner is unvaccinated or not fully vaccinated. Because you know that tenofovir and possibly entecavir monotherapy can cause HIV-resistant infection, so all HPV patients should be screened for HIV before we start this treatment for HPV, because we give mostly monotherapy for the nucleoside antidote, we give monotherapy in hepatitis B, but if we give monotherapy in patients with HIV, there is chances of developing resistance to these organisms, so you should be very careful that you should screen HIV in all patients who are affected with hepatitis B. What is the treatment goal? So there must be some treatment goal which we have to achieve. We can take it as a long-term treatment goal and short-term treatment goal. The long-term treatment goal in hepatitis B is to decrease the mortality by preventing the development or preventing the progression of liver cirrhosis and or hepatocellular carcinoma. And how this is achieved? This can be achieved by clearing the HPCAG, which is very difficult, or long-term maintenance of undetectable HPV DNA level, which is mostly possible with the latest available NA analogs. The short-term goal, what is the short-term goal? This will vary with hepatitis E positive patient and hepatitis B positive patients. In HBE positive levels, HBE positive hepatitis, the short-term goal is the normalization of ALT level and making the HPV DNA undetectable and the clearance or zero conversion of HPCAG and E antigen. You know, the clearance means the disappearance of HPCAG or clearance of HPE antigen means the clearance of HPA. But zero conversion is converting the HPCAG into anti-HBs, and zero conversion of E antigen indicates disappearance of E antigen with anti-HB formation. So in patient with E negative hepatitis, the treatment goal is only normalization of ALT and make an undetectable HPV DNA level. So the adult patient which require chronic hepatitis treatment include the following. That is, first one, the HBE positive chronic hepatitis. How to diagnose E antigen positive hepatitis? The ALT level of more than 80 units, or if the ALT is between 40 and 80 and the fibrosis and moderate necroinflammation or fibrosis as evidenced by non-invasive tests for liver fibrosis or liver biopsy. And HBE negative chronic hepatitis is diagnosed by having a DNA of more than 20,000 international units or HPV DNA of more than 2,000 and ALT of more than 80, or HPV DNA more than 2,000 IU, but the non-invasive test of fibrosis or liver that is fibroscan or liver biopsy showing moderate necroinflammation or fibrosis. The following groups of adult patients, in addition to what I have described as HBE positive chronic hepatitis and HBE negative chronic hepatitis, there are other patients who also require antiviral treatment. Those who have cirrhosis, whether they are compensated or decompensated, where they have to be started treatment regardless of ALT level, HBE status or HPV DNA levels. The other situation where the ALT levels, E antigen status and HPV DNA levels are not required to start treatment is a patient with liver failure, that is acute liver failure or ACLF, and also patients who are having extrahepatic manifestation of hepatitis B, and also when there is a family history of cirrhosis and HCC. Previously, we don't treat patients who are having a DNA of more than 2,000 IU. But if the treatment, if the ALT level is normal or E antigen status is normal, we don't treat them. But now the latest guideline says, if the patient has got a family history of cirrhosis or HCC, even when the HPV DNA is more than 2000, irrespective of the ALT level or E antigen status, there is an indication for antiviral therapy. Patient in immunotolerant phase, for example, patient with HPV DNA of more than 20,000, E positive, ALT persistently normal. Now, previously we don't treat. Nowadays, there's a slight change in the recommendation. Patient may be treated if aged more than 30 years, but they should not be treated if the age is below 30 years. The recommendation level is B1. Patients in inactive carrier phase, that is E antigen negative chronic infection, do not require antiviral treatment. Patients in inactive carrier phase are those who are HBe negative with one of the following features, that is DNA less than 2000 or DNA between 2000 to 20,000 IU and the ALT below 80 and minimal inflammation and fibrosis in liver biopsy or assessment by fibroscan. So this shows the algorithm of treating the HPE antigen patient. Here you can see that when the patient is HPE positive, and if you exclude cirrhosis and extra hepatic manifestation, no ALF, no ACLF, no family history of cirrhosis and HCC, we can divide them into three categories: ALT more than 80, ALT less than 40, and ALT between 40 and 80. If the patient has got ALT more than 80 and the DNA level is 20,000, you know, it goes by the definition, this patient has got E antigen positive chronic viral hepatitis B, and this patient requires antiviral treatment. If the ALT is below 40 and the DNA is above 20, it is called immunotolerant phase, and this patient is not required treatment. For some patients who are more than 30 years, still we can give treatment for this particular type of patient who has got a persistently low ALT, but the DNA is 20,000, and though it is in the immunotolerant phase, if the age is 30, you can still start the antiviral treatment according to the latest guidelines. What is there for ALT between 40 and 80? When the DNA is usually more than 20,000 in these people, and non-invasive treatment or liver biopsy is recommended. If you find moderate inflammation, necroinflammatory inflammation or significant fibrosis, you can treat it as a HPE positive immune reactive phase, and this set of patients require antiviral treatment. And if the minimal inflammation and fibrosis on evaluation, if they find patient is called as immune tolerant phase, or it is called E antigen positive chronic infection, not hepatitis, it's called chronic infection, and they doesn't require treatment. Coming to the HBe antigen negative treatment naive patients, you find out the E negativity, and if there is actually no cirrhosis or extrahepatic manifestation, no ALF, no CLF, no family history, again you divide into two categories. If it's more than 80 and less than 80, if it is more than 80 and the HPV DNA is 2000, you can call it as a HPV negative immunoreactivation phase or E antigen negative chronic hepatitis. They require an antiviral treatment. If you take the HPV DNA below 2000, it is called most likely an inactive carrier, and it is called E antigen negative chronic hepatitis. Antiviral treatment is not required. In patients who are having ALT below 80, we divide it into three categories. One is the DNA of more than 20,000, and DNA of less than 2,000, and DNA between 2,000 and 20,000. You see, the patient with HPV DNA of 20,000, we call it as a HPV negative immune reactivation phase, and those people require treatment. For patients who are having DNA less than 2,000, called as an inactive carrier or HPV negative chronic infection, doesn't require treatment. Similarly, the range between 2,000 and 20,000 depends upon the necroinflammation score on liver biopsy and fibrosis. If it is moderate necroinflammation and fibrosis, you treat it as HPV negative chronic hepatitis, and they require antiviral treatment. Those who doesn't show significant minimal inflammation, those who doesn't show much fibrosis or minimal inflammation necrosis, they are treated as inactive carrier and they don't require treatment. So what about the treatment algorithm for patients with cirrhosis, liver failure, extrahepatic manifestation of HPV, and family history of HCV and CCSE? You all know all these patients require treatment irrespective whether the ALT is normal or raised, whether the E antigen is positive or not, whether the HPV DNA is significant. But it's only one category in which the family history of cirrhosis and HCC is there. If HPV DNA is there, is more than 2000, regardless of ALT and HPV-E status, these patients require antiviral treatment. So what are the drugs that are available? We know that now present day only 3 drugs are available: tenofovir, disoproxil fumarate (DDF), tenofovir alafenamide, and entecavir. Pegylated interferon, we don't use it much, but there are some indications for it. All drugs should be used as monotherapy. Combination therapy or sequential therapy of NA and pegylated interferon is not recommended at present. Of course, yesterday Dr. Joy Verghese told few trials which are combining dual drugs, but it is not still recommended, though there are a lot of trials available. And following drugs nowadays should not be used for treatment, that is lamivudine, adifovir, telbivudine, are not recommended for use in HPV infection because of the high resistance. What are the oral antiviral therapy is with the tenofovir and entecavir is preferred, and pegylated interferon has got can be used with careful monitoring of liver function and side effects, especially in patients with compensated liver cirrhosis and preserved liver function. The use of pegylated interferon alpha is contraindicated in patients with the decompensated liver disease due to high risk of complication precipitating hepatic failure. Patients who do not fulfill any of the above treatment criteria, that is the E antigen positive chronic hepatitis, E antigen negative chronic hepatitis, and a patient who has got cirrhosis and ALF, ACLF, and family history of HCC or cirrhosis. There are other patients we fall into the group. They are the patient with the HPV DNA of more than 2000. And these patients, how they should be monitored? The patient with the DNA of 2000 units should have ALT determination every 3 to 6 months, and DNA recommended to be done every 6 to 12 months, and assessment of liver fibrosis should be done every 12 months. And patient with having less than DNA of 2000 units should have ALT determination every 6 to 12 months, and periodical HPV DNA and liver fibrosis assessment is required not every year, they may be done once in 2 to 3 years. So how to monitor patient, now we have seen patient, how to take care of the patient who are not fulfilling the treatment for hepatitis B. Now we will go to how to monitor patients who are on antiviral treatment. So during antiviral treatment, you have to have close monitoring of the side effects of each drug is mandatory. First important is the monitoring of the drug compliance of the patient, whether the patient is taking the drugs properly, because most of the treatment failure is due to the non-compliance of the patient and not due to the drug. And you should see whether they are adherence to the antiviral treatment, and because if they don't do so, they may lead to increased drug resistance and treatment failures. So all the patients who are on NA should be followed with periodical assessment of ALT and serum DNA. Following patients should undergo periodical renal monitoring, especially those who are on tenofovir. And patient on tenofovir at the risk of developing an underlying renal or bone disease should be considered to switch over from entecavir to tenofovir. All patients who are treated with pegylated interferon should be monitored for periodical assessment with CBC, ALT, TCH, because they may develop hypothyroidism, and E antigen, anti-HPV, HPV DNA, and HPV levels. Surveillance of HCC is more important when you are treating the patients, monitoring the patient antiviral treatment, and HCV surveillance is mandatory for all patients with cirrhosis, as well as those with medium or high HCC score at the onset of the therapy. Patients of decompensated cirrhosis should be closely monitored for tolerability of the drugs and the development of rare side effects like lactic acidosis, as you see with entecavir, or kidney dysfunction, which we see with tenofovir. But with tenofovir alafenamide, the renal toxicity is supposed to be reduced. And this is the scoring system for predicting the development of HCC, and you see that the age more than 50 years, albumin less than 3.5 milligrams, and bilirubin of more than 1.1, and HPV DNA of more than 20,000, presence of cirrhosis are all the high-risk factors for developing HCC when you follow up the patient with chronic hepatitis B infection. So there are a lot of terminologies like virological response, complete virological response, partial virological response, primary virological non-response, sustained of therapy virological response, virological breakthrough, biochemical response, biochemical breakthrough, histological response, serological response for E antigen, serological response for HPV, which are all these are all lot of definitions which will be which will be useful in monitoring the patients with treatment. And treatment failure, when you consider that there is a treatment failure on patient on therapy, when there is a primarological non-response. What is primary virological non-response? Is less than 1 log decrease of HPV DNA after 3 months of therapy. That is, you treat the patient with NA, and if you see after 3 months, if you do the HPV DNA, if there is less than 1 log reduction, you call it as a primary virological non-response. And then there's a partial virological response. Partial virological response is the decrease of DNA is more than 1 log, but it is detected still after after starting 12 months of nuclear analogs, provided the patient is compliant. Then we call it as a partial virological response. Then what is virological breakthrough? Virological breakthrough is nothing but the increase in HPV DNA of more than 1 log compared to that is the lowest level on therapy. So these are the 3 important points. If you encounter these 3, you call it as a treatment failure. And as I stress again, the compliance with therapy should be checked in all cases of treatment failure. How to assess the treatment response also? Treatment adaptation should be performed as soon as the treatment failure under NAS is confirmed and should be based on NAS cross-resistance data. And for patients who are treated with a drug with a high resistant genetic barrier, treatment should be either switched over to another drug with the same high genetic barrier to resistance, or be continued with the monitoring for a viral response at 3 to 6 months interval. For patients who are treated with a drug with a low genetic barrier to resistance, treatment should be switched over to a drug with a high genetic barrier to resistance. Antiviral resistance should be performed when virological breakthrough occurs, especially in cases you find that the patient has got a good drug compliance, but still patient had a virological breakthrough. Look for the antiviral resistance, and rescue antiviral therapy should be started as soon as possible upon the emergence of resistant variants, especially when viral breakthrough is detected and genotype resistance is confirmed. And these are all the predictors of pegylated interferon alpha response. The main, in HBE positive patients, the predictors are low viral load, high ALT, genotype A and B is more susceptible to PEG interferon than C and D, high activity score on liver biopsy and on treatment HbA1c levels. And between E antigen and E positive predictors, the younger age and female gender are additions which you see in E antigen negative patients, predictors for interferon therapy. So, what are the stopping rules of pegylated interferon therapy? In E antigen positive chronic hepatitis patient, at 12 weeks of pegylated interferon therapy, if the HbA1c levels are more than 20,000 units, or for genotype B and C, and no decline in HbA1c levels for genotype A and D, are associated with a low probability of subsequent E conversion and can be used termed as pegylated interferon stopping rule. At 24 weeks of pegylated interferon therapy, if the HbA1c levels are more than 20,000 for any genotype, is associated with a low probability of subsequent E antigen conversion and can be used as pegylated interferon stopping rules. In E negative chronic hepatitis patient, at 12 weeks of interferon therapy, if you don't see a decrease in HbA1c levels and less than 2 log reduction in HPV DNA levels, predicts no response and should be used as pegylated interferon stopping rules. The cessation of antiviral, when you stop the antiviral treatment, the pegylated interferon treatment should be stopped at 48 weeks or at 12 or 24 weeks if stopping rules are met, which you already discussed. In patients who are receiving NAA, the treatment should be stopped if the hepatitis A antigen loss is achieved with or without anti-HbA seroconversion. The second most important point is for E antigen positive patient, at least 12 months after the HPV DNA is undetectable and E seroconversion or seroclearance is obtained, you can stop after 12 months. For E negative patient, long-term virological suppression is achieved, that is 3 years, but however it requires close NA monitoring should be guaranteed in those patients with E negative patients. And antiviral treatment should not be stopped in cirrhotics. That is very important. You can stop the antiviral irrespective of HPV DNA level or ALT level or E antigen state, E antigen level in cirrhosis. Once started, it should never be stopped. And you remember, in patients with decompensated liver disease, the dose of entrecavir should be raised from 0.5 milligram to 1 milligram in patient with decompensated liver disease. So what is to do after cessation of antiviral therapy? You can't just leave them like that. During the first year after cessation of antiviral therapy, LFT should be monitored and serial HPV DNA should be measured every 3 months. And E antigen and anti-HBV should be checked out after 3 months, 6 months levels. Beyond 1 year, after cessation of antiviral therapy, liver function and DNA should be tested every 6 months to detect the viral response. And HCV surveillance is mandatory for all patients with cirrhosis, as well as those with moderate or high HCC scores, which I have already discussed, even after stoppage of antiviral treatment. Normal recommendation is you ultrasound screening every 6 months, because why you do every 6 months is the doubling rate of HCC is 6 months. So HCC will become twice the size in 6 months. So that's why we insist on doing HCC, the ultrasound in every 6 months. So when you suspect HCC based on ultrasound and alpha-fetoprotein, you can as well go ahead with the CT scan and dynamic study. What is the, now we see we have to prevent the HPV recurrence after liver transplant. Pre-transplant therapy with NA is recommended for all HPCG positive patients who are undergoing liver transplantation to achieve the lowest possible of HPV DNA, preferably undetectable before transplantation. So patients who are high risk for developing recurrence, that is those who are having HPV DNA positive at the time of liver transplantation, those who are E antigen positive, those who already have a HCC, and HTV or HIV co-infected should receive lifelong combination therapy of NA plus hepatitis B immunoglobulin. Patients with a low risk of recurrence can discontinue HPV immunoglobulin, but need continued monoprophylaxis with a potent nucleoside analog. In selected patient, hepatitis B immunoglobulin-free regimen from start also may be considered. In E-negative patients receiving livers from donors with the evidence of past infection, that is anti-HBC they are positive, but HBsAg is negative and DNA are negative, are also at risk of developing HPV infection and should receive antiviral prophylaxis with nucleoside analog indefinitely. All HIV patients with HPV DNA co-infection should start antiviral therapy irrespective of the CD4 count. And you remember that you should, since we are giving a monotherapy with all patients with chronic hepatitis, you should be very careful to exclude HPV infection, HIV infection, because this can develop resistance. And so HIV, HPV co-infected patients should be treated with the TDF or TFA-based ART regimens. So the ART regimens which are going to treat the HIV should have tenofovir or tenofovir alafenamide. In HTV co-infected patient, the treatment of choice is pegylated interferon for at least 48 weeks is the current treatment of choice in HTV infected, co-infected patient with compensated liver disease. In HPV co-infected patient with the ongoing HPV DNA replication, NA therapy also should be considered. Pegylated interferon therapy can be continued until 48 weeks, irrespective of on-treatment response, provided the patient is able to tolerate the drug. Irrespective of the response, they should complete 48 weeks treatment. The most another important co-infection which you have to tackle is the occurrence of hepatitis C along with B. Treatment of HCC with DAA can cause reactivation of hepatitis B. So patients who are fulfilling the standard criteria of HPV treatment should receive the NA treatment. HPCG positive and patients who are undergoing DAA therapy but not fulfilling the HPV treatment criteria should also be considered for concomitant NA prophylaxis until week 2 after the DAA and should be monitored closely. In HPCG negative and anti-HBC positive patients undergo DAA should be monitored and should be tested for reactivation of B in case there is an ALT elevation during the treatment. Most adults with uncomplicated acute hepatitis B hepatitis do not require antiviral treatment because more than 70 to 80% of them they recover in the acute hepatitis and they will fully recover spontaneously. Patient with got severe disease, acute hepatitis, that is a bilirubin of more than 5 milligrams, if INR is more than 1.5, and the disease is lasting 4 weeks, they said to have a severe acute viral hepatitis or severe acute reactivation of chronic hepatitis B. So these patients are at risk of developing an acute liver failure or ACLF, and they merit treatment with antiviral with NA. Patient with acute liver failure or acute or chronic liver failure due to HPV should be immediately started on NAE and should be also have a listed for liver transplant, which may they require in the course of the disease. So what is the treatment of indication children? Like in adults, if they have a cirrhosis, don't bother about the ALT level, E antigen status and HPV status, you treat. And your treatment is not required in the immunotolerant phase in children also, that is DNA more than 20,000, E positive and normal LLT, and liver biopsy also is not required, there's no treatment. But if the DNA is more than 20,000 or 20,000, irrespective of whether E antigen is positive or not, when the ALT is elevated more than 80, you treat the patient, you treat the children. And if the child is having DNA of more than 20,000, E antigen negative, and ALT is less than 80, and if the non-invasive test of fibrosis shows significant fibrosis, or if the liver biopsy is done and shows moderate necroinflammation, then you treat the child. To sum up the treatment in children, antiviral treatment should be considered for following patients. E antigen positive children with a DNA of more than 20,000 when the ALT is more than 80. E negative children with HPV DNA of more than 20,000 and the ALT level is more than 80. Or when the liver biopsy shows moderate necroinflammation or moderate to severe necroinflammation or peripheral fibrosis, you can treat the patient. Children with cirrhosis should be immediately started on NA therapy. Antiviral therapy is not indicated children in immunotolerant phase, that is E antigen positive, DNA more than 20,000, normal LLT. In children or adolescents who meet treatment criteria, the entecavir, or TDF, or TAF, or pegylated interferon, if indicated, can be used. What about the healthcare workers, how to take care of them? Unvaccinated or incompletely vaccinated healthcare patients with reasonably increased anticipated risk of blood and blood-free exposure should receive hepatitis B vaccination. Vaccinated health workers should receive post-vaccination serological testing, that is anti-HBs titer, 1 to 2 months after they complete the full course of vaccination. HPV infection alone should not disqualify the infected person from practice or study of surgery, dentistry, or medicine, or allied fields. They can still pursue the career. Health workers performing exposure-prone procedures with a serum DNA of more than 200 must be treated with NA to prevent transmission risk from them to the patients. In pregnancy, what to do in pregnancy? All HPV positive patients of childbearing age should be counseled about the implications of pregnancy, the risk of mother-to-child transmission, and the safety of drugs during pregnancy and lactation. Hepatitis B women of childbearing age who is planning pregnancy in the near future should be treated with antiviral drugs that belong to pregnancy category drugs, that is B drug, preferably a tenofovir, or be advised to delay therapy until the child is born. Pegylated interferon has an advantage in female patients who are planning pregnancy due to its definite treatment duration. However, side effects pertaining to fetal malformation making it contraindicated during pregnancy and should be recommended only in combination with contraception. Screening of HPV in the first trimester of pregnancy is strongly recommended, and patients who are pregnant who are on NA therapy, the tenofovir should be discontinued while entecavir or other NA therapy should switch over to in pregnant women who are already on nucleoside therapy, tenofovir should be continued. If the patient is on entecavir, you should change over them to tenofovir. Should be switched over to tenofovir. In all pregnant women with high DNA levels, that is 22 lakhs units, or HbA1c levels of more than 4 lakhs, antiviral prophylaxis with TDF should be started at the 24th to 28th week of gestation and should continue up to 12 weeks after delivery. And newborns of HPV infected mother should receive the hepatitis B immunoglobulin immediately after birth and should receive the first dose of hepatitis B vaccination and should complete the course of hepatitis B vaccination. Breastfeeding is not contraindicated in HPCG positive untreated women or on TDF based treatment or prophylaxis for these people. And Prior to, what about the immunotherapy? What are the patients undergoing immunotherapy? What are the recommendations? Patients, prior to initiation of immunosuppressive treatment or chemotherapy, the screening with HBsAg and anti-HBc Ig recommended. If either positive, serum HPV DNA should be done. Patients without evidence of HPV infection should be vaccinated. And consider preventing antiviral therapy with entecavir or tenofovir alafenamide simultaneously with the initiation of immunosuppressive treatment or chemotherapy if HBsAg or HPV DNA is positive. Patients undergoing immunotherapy, and there are other recommendations, if anti-HBc IgG is positive without HBsAg or DNA positivity, irrespective of anti-HB status, serum HPV DNA and HBsAg should be tested regularly, and preemptive antiviral therapy should be considered if reappears during immunotherapy. Preemptive antiviral therapy in patients with isolated anti-HBc can be initiated in high-risk groups, such as patients with lymphoma undergoing rituximab therapy containing regimens, or those with leukemia who undergo hematopoietic stem cell transplantation. Serum HPV DNA should be monitored periodically during and after preventive antiviral therapy. Preventive antiviral therapy should be maintained for at least 12 months, 18 months for patients who are receiving rituximab-based regimens. After the termination of immunotherapy therapy, the prophylaxis should be considered for 12 to 8 months. And for dialysis patients, all dialysis and renal transplant patients should be screened for HPV markers. Vaccinations recommended for all patients who are undergoing dialysis. For negative, or even for under dialysis, negative for HBsAg and anti-HBs. Oral NAs such as entecavir and tenofovir are preferable to interferon therapy in patients who are undergoing dialysis. And nuclear anesthesia should be dose adjusted according to the residual renal function. All HBsAg positive renal transplant recipient should receive entecavir or tenofovir as prophylaxis on treatment. HBsAg negative anti-HBc positive subjects should be monitored for HPV infection after renal transplantation. Patient with extra hepatic manifestation, patient with the scenario in extra hepatic manifestation is the patient with a replicative HPV DNA infection and extra hepatic manifestation should receive antiviral treatment. And pegylated interferon, of course, should not be administered in patient with immune-related extrahepatic manifestation. This is contraindication if it is immune-related extrahepatic manifestation. So, now we are coming to the conclusion, and we know that there is a large burden of HPV DNA in India. The currently available therapeutic armamentarium for treatment or treatment for chronic hepatitis is definitely far from ideal. Apart from poor HBsAg clearance, the big hindrance to the treatment is currently available therapies. With the currently available therapies, the big hindrance is the persistence of cccDNA, which has significant clinical consequences. Yesterday, Joy very nicely explained the presence of a free cccDNA as well as the cccDNA which is incorporated in the genome of hepatocyte and how that becomes difficult to treat. Now, understanding the cellular and molecular mechanism involving the HPV replication and cccDNA dynamics is very pivotal in devising more effective strategies. And now, a lot of new drugs as well as vaccine targeting cccDNAs are in the pipeline. And when we get when these 5 molecules or vaccines are effective, probably we'll find a cure for the hepatitis B in the near future. So existing targets have been identified, which will definitely hint at a better treatment outcomes, including achieving the elusive complete cure in HPV infection. Considerations for the treatment of HPV DNA should include the cost of the therapy, the socio-economic status, and prevailing poor healthcare infrastructure in India. Thank you. Thank you for your patient reference. At the outset, I thank the ISGCon team for excellent arrangements and excellent academic feast they offered in Trichy today. And I'm very thankful for giving me another wonderful opportunity to deliver the Professor NMG oration. And I thank everybody for the patient listening. Thank you.
Thank you, sir. And on behalf of the Indian Society of Gastroenterology, Tamil Nadu chapter, We are honored to present this scroll to Professor Dr. A. Murli for delivering Professor N. Madanagopal oration at TNA Tnisgcon 2023, Trichy on 26 March 2023.
Almost coming to the fag end of the conference, but I do not know whether to feel happy or whether to feel sad to introduce Professor Balasubramaniam to all of you. As you know, he did MBBS in Stanley Medical College. When he was the MD, he was my student. So when he joined DM, he became very close to me. A lot of politics in the department. He was the bridging stone. I used to get upset often. He was the bridging stone, so calm me down. And I was very much attached to him. And in 2003, next slide please. Slide please. I'm sorry, no. Bala. In 2003, when we organized this is how close he is to Palanisamy. And in 2003, when we organized the conference, he's already developed rheumatoid arthritis. He cannot move about, but still he was the pillar of the strength and organizing everything from scratch to bottom to become, and this is the vote counting. Nowadays they are doing the electronic counting. Now it's a manual counting at that time to announce the election of office bearers next academic year. Next please. And this is the governing council meeting in 2005 at Ooty. And in spite of his being in wheelchair, he used to come. Except last 1 year, he could not attend. Every time he was wheelchair bound, he used to come to the conference and take active part. Now, next slide. And very good. He was a very good philosopher, guide, and mentor for many people. And calming down, not getting short-tempered, not getting this thing. So he was a nice person, but unfortunately, everybody has to go one day, right? And my students are going, I'm still alive. And next please. This is mainly responsible for this journal, though effort was put by others, but he is the man who sanctioned the funds for the release of the journal. Can I have that explained? He has got a helping tendency, very humble, very compassionate. Problem solving is the most important. You solve the problems. Raghuram sir, KR sir, don't get worried. It will solve. You be rest assured, it will be solved. There won't be any other further handling. Handling and crisis and emergent situation. And a very great friend and philosopher for me. So now I give the mic to mic to Professor Panisamy to invite the speaker.
I'm really honored to introduce the orator, Dr. Kardas Chaudhary, fondly called as GC. He's a very good friend of not only mine, Dr. Bala, and also to TNISG. Dr. Kardas Chaudhary, he did his gastroenterology from All India Institute of Medical Sciences, later moved to the Sanjay Gandhi Institute of Postgraduate Institute, and he sort of moved the department to greater heights. And today is one of the top institutions in the country. And during his tenure there, I don't know how many of you are aware, he was one of the first to start endoscopic ultrasound and even the ESWL in the country. And he's a great academician, researcher. He has got more than 200 publications to his credit, chapters in the textbooks, and he has delivered several orations and received awards. Of course, we can keep going speaking about him. The other important aspect which I would like to mention to you is Dr. Chaudhary was the secretary of ISG for 6 years. During his tenure, we held this conference, the Tamil Nadu ISG conference in 2003. It was held during his tenure as secretary. I think he was really instrumental in the great success of the meeting. Even today, it is talked of as one of the very good meeting organized. So that is really in the great memory of many of us. And during his secretaryship, he had a lot of initiatives. Like he brought in this the YCP, Young Clinicians Program, GEM program, and currently he is holding another program called GEM. That is for the young gastroenterologists excellence program. I think it was held recently in Bombay, about 3 weeks back. And the other important thing I would like to mention here is, he has got a foundation. It's called Hope Foundation. Under the Hope Foundation, he is doing a lot of activities. That is for educating younger children in hygiene and health. And in Lucknow, and in the state of UP, and he has sort of held it in several hundreds of schools. And even some of the governments have taken this program due to his initiative. Really, it is appreciable. And apart from that, under the Hope Foundation, he is holding this NFLD conference, NFLD conclave every year. This last week it was held in Delhi. There was a 6th edition. That was one of the very nice, important meeting and with international presence. So without wasting much of time, I can go on talking about Dr. Chaudhary. I would like to invite Dr. GC to deliver Dr. Balasubramaniam oration.
Can I have my slides? I must tell you, I'm deeply honored with this great, shall we say, trust that you have posed in me. And it's a big honor to come and give an oration in Tamil Nadu chapter, particularly for a dear old friend I've known for many years. Next, please. I was talking to my friends, and I have a lot of them here, including Rama, that should it be a somber talk, because this is a memorial oration, or should it be a cheerful talk? So you can see Rama is never very serious. So his advice was that let it not be too serious, because we have all known Bala, and Bala has always been a cheerful person. So anyway, I dedicate this talk to Bala. See, the first thing that comes to mind when you think of Bala was Tamil Nadu ISG leadership going to him for help. So everybody doesn't have to be a great researcher, but leadership was in his blood. So I thought I'll talk today a little bit of a reflective talk. So all of you have been attending conferences, delivering talks. You know, there are 3 types of talks. The first is an information knowledge-based talk, which is the commonest we hear. Right? I mean, what's the composition of stones, what causes pancreatitis, how to manage. Others are thought-provoking, something like a debate where there is an opinion given. And the third type is called a reflective type of a talk. So I'll be talking in abstract general terms, but each of you would have to apply some of what I'm saying to your own lives and see how does it matter. Because we are, after all, not a herd of animals going in a particular direction. We all have our own individual stories to tell and purposes to solve. So why do some follow while few lead? That's a very difficult question. So while preparing this talk, I was thinking about leadership. And you see so many leaders here. So this is a pack of wolves. And leadership happens from ants to insects to birds to animals to humans. And all species sometimes demonstrate that there would be few people going in front, okay, and there would be a lot of people following. So what makes some people be in front and other people follow? Ever thought of it? I mean, why did Bala have to come in front, KRP have to be in front, TSC have to be in front, whereas, I mean, some of us are quite comfortable doing our little practice and enjoying our Tair Sadham. So, I mean, I'm a passionate Tair Sadham lover. So some lead and others follow, and it really occurs across many different species. So I grew up in a place called Jamshedpur. This was in Jharkhand, and they have a whole lot of animal herds, and they follow a similar pattern of behavior. That and it's not just the mother elephant looking after the cub or the baby elephant, but the herds move with a leader. I mean, you can talk about an alpha male type of a personality, but these are the areas of thoughts for research for Rama, because he's the best researcher I know in this part. So the probable reasons why this leadership and following mentality goes on is that most people, again, I can't do a questionnaire survey with elephants and wolves, but I presume most of the followers would feel that if you follow a leader who sounds very confident and seems to know the way, it enhances the chances of my survival and getting food. Okay? And the leader has to exude a lot of courage, confidence, and experience or wisdom. I mean, he may take you to the guillotine, that's a different issue, but the fact is, by the way, Rama told me to make the talk a bit light, so if I am at fault, blame Rama. But, I mean, on a philosophical note, leadership means you're taking somebody in a particular direction. Most followers are often not in a position to know where exactly we are going. Most of the time it is good. Sometimes it may not be. I mean, you can see what's happening in Ukraine, for instance, but that's a different issue. Now, from animals to humans, the phenomena is the same. This, by the way, at least my students should be able to identify who's this girl. Pirama, if you don't identify, I'll be very disappointed. Yeah, she is a big-time person now, and environmental activist, Now, again, you find that she's able to draw large crowds and inspire and motivate people to bring governments to take action on climate. And to an extent, if you look at what happened to the wolves or the elephants, here also there is an element of survival of the species. What they now describe in environment as a crisis in which we are heading for what is called as a mass suicide. So it has an appeal that if you think that we need to survive for 2 generations or so, and she's able to do rather well, at least keep the debate going and keep it in balance. most of us are familiar with strikes. I think now there is a WhatsApp going on, that there has been a new health bill. So strikes, incidentally, when I joined JIPMER in 73, that year there was a strike. And the year that I left in 78, there was a strike. And then when I joined All India Institute, I think it was in 80, there was a strike. And that was a useful strike. By the way, we used to get 400 rupees as a stipend, which at least went up after that strike. And then when I left AIMS, there was a strike. So strikes are very emotive issues. And, you know, it's easier to get people onto your side and motivate them to come and form queues and shout slogans on emotive issues. But emotive issues, obviously, as you understand, they won't last long. They are only for a limited purpose. You either solve it or you're broken and then you go your way. So quite a few of these emotive issues also throw up leaders. And it was interesting, I was talking to the Chief Minister of UP, who happens to be my friend, not the present one, the previous one. And most of the people in state politics have actually started their lives as student leaders. I'm sure it happened here also. You can talk to the person. But you know, that is how you start developing and honing your skills of leadership. So I'll come a little bit more closer to home, that is medical leadership. And medical leadership is all about having teams with a leader who more or less is able to regulate and inspire people as to what to do. For example, no matter how much Chandrasekhar says that he does everything by himself, I'm sure you have trained a couple of nurses and some technicians to help you to get the good results, okay? And every endoscopist is very passionate about that team. You know, how you train them, giving the right instrument when you need it most. So team dynamics and task performance require group functioning with a leader, and he has to be able to motivate and get other people to deliver. And doctors by nature, ever since you have become an MBBS, you are a leader because you have to lead a team. You can't do anything by yourself. So even if you're doing OPD practice, you have to have 2 or 3 people who are going to receive the patients, counsel them, so on and so forth. Endoscopy units, I give you an idea. If you are doing gastroenterology, any unit serving patients, there's always a team, the nurse, the technician, the orderlies, and so on and so forth. And the bigger and more complex the task, the team becomes bigger. And therefore, the leadership requirement goes up. For example, we just held this career counseling mentorship program in Bombay. You see, those who are in very small individual practices, they are very happy with 5 people working in the team. As soon as they start putting in new things, like say 3 different types of advanced procedures, the team expands. Now, if you see the most complex procedures, these are liver transplants. Now, liver transplants usually require big teams. And that's probably one of the reasons why most of the government hospitals are not able to get a very good program running, because it's too loose. You can't really have control on too many people. And therefore, the private sector has gone because, you know, they would pay you, coerce you, do whatever you want, but they would have a team because ultimately you have to deliver. Okay? Now, what is it about leadership in healthcare? Leadership in healthcare is all about giving a sense of direction and goal. So if suppose TSC is doing a procedure in which he is using a spyglass, it's a complicated case. He would have, that patient must have had 2 or 3 attempts elsewhere. You have to be able to do it. You have the fellow giving the this thing, image intensifier, and you know, the fluoro. You have your assistant and so many other things. So you have to say that, okay, this is my goal, and you have to train them, and that's how you go. And you have to convince and motivate and recruit others to have the same passion to do what you're doing. The goal remains the same. Okay? And guide them on a journey to achieve the goal. And you know, this guiding them is important because you know how difficult it is to train a team. And if your attrition is high, which is one of the major problems in many hospitals, including ours, you know, you then start again, all over again, starting from scratch. It can be very difficult. So that's why you have to create a team, inspire them, motivate them, and retain them. Now, what are the qualities of a leader? Several of them. It almost lists, the list looks like all the qualities you would attribute to any national leader, say Mahatma Gandhi or Nelson Mandela. So that I'll leave it to you. But yes, you must be able to earn the people's trust to trust you as a leader. And only then it makes sense and inspires some confidence. Now, medical leadership, and I'm sure all of you are going to become leaders, many of you. I can already see it happening in a lot of you. The present ISG secretary is doing extraordinarily well, and many seniors are showing the way. So there has been something called a traditional approach. A traditional approach is a person who's very altruistic, very high. I mean, everybody refers to Dr. Madan Gopalan. I'll show his picture also. So you talk of Dr. Madan Gopalan, it's first thing that comes is awe. He's just great. So he's altruistic, committed, sincere, hardworking, personalized care. So that was actually the phase that leadership went through. I think now people are becoming a little more specific in the sense that if you have complex jobs to do, is the skill development for individual purposes good enough? When you move from a clinic to an endoscopy suite to a department to a mini hospital, and then a hospital chain. We have VG Mohan Prasad and TSC having their own hospital. So, the complexity grows. It is no longer just endoscopy being done. Okay. And then when you aspire to become bigger leaders, and bigger means your zone of influence needs to grow bigger, then you think that, look, is Chennai good enough or Tamil Nadu good enough? Or should it be a chain in South India or a national chain? So that is how you think in terms of moving up. So formation of a team requires a leader and performers of complex specialized tasks. And I'll come back to this modern aspect of leadership. For example, one person who's giving the fluoroscopy has to know exactly how to give the fluoroscopy. That person need not know how exactly to look at the respiratory passage and the mouth guard. If he does, it's fine, but you're expecting him to do only that part well. So similarly, distribution of complex tasks is very important when as a leader you decide to build a team. And who becomes a leader? So here is a little complex issue. Leadership is a trait that some people have. So I just gave you the example of the wolves and the herd of elephants. Some people emerge as leaders. One of the problems that often happened in my own experience, I would say, is senior people becoming leaders. Sometimes it works. Obviously, there is at least something to go by. He was senior to you. But more often than not, it often means that you're compromising on a quality and putting somebody there just because he's senior. The examples are, say, with the judiciary, for instance, or with the army or defense, for instance. So it's a delicate balance, because whenever you move from one set of rules to another, there would be hue and cry. But whosoever decides on leadership has to therefore decide what are you going by, because the end point is realization of that goal. Now, performance, suppose I'm talking about a department like, say, Rama left, I think he didn't like my bullying. So if you have to lead a department of gastroenterology in, say, CMC Vellore, who would become a leader? Just a senior guy, or somebody who has done wonderful research, has got a long list of publications, is able to get a lot of grants, or has a lot of contacts to get ICMR grants from Delhi. So these are difficult issues, and sometimes a little bit of rivalry within limits is okay, but beyond some time it actually becomes a bit of a distractor. Now, talking about leadership styles, this is an important issue because we have Palani Swami here. In our time, it was at the number 2. It was called the autocratic style. So Dr. B.N. Tandon was obviously a very big gastroenterology leader, but he was autocratic. And if I remember right, I have met Dr. Madan Gopalan. He was also fairly autocratic. I think VG used to tell how scared he was of. So democracy may not always work because, in a government institute, for example, how do you have people to decide who would become the leader? So it doesn't often work. Transactional seems to work in a private setup because, ultimately, if you are able to do so much with so much of good quality outcomes, then you have some relationship, reward. Relationship oriented, again, a slightly oldish school of thought, but in small clinics it works. He's like a father figure. So his daughter's wedding, I'll give the money. That kind of rapport building and all that. And task oriented. But the most important is transformational. That is, if I am spending my 3 to 4 years with you, how would you transform me in my career and in my life? So many of the autocratic leaders, including Dr. B.N. Tandon, I must say they have been transformational, but they belong to a particular time when that was the style. And now people are becoming less accepting of autocracy. I mean, if you see with your own children, for instance, there is a change. So the old versus new approach is that the old approach was more authoritative. In fact, I have seen young parents now coming to me helpless. The children don't listen to me. They want burgers every day. Yeah, so authoritativeness doesn't work. So it is moving more towards a persuasive approach. And especially in a very functioning united team, you need to have a very good combination of a persuasive approach. How important is it to become a leader? You see, obviously, if you see leaders sitting on the dais, everybody wants to become a leader. Who doesn't? Anybody here who doesn't want to become a leader? It's okay. So I think generally most do, because many may have it in them, genetic, constitutional. They are often attracted by the importance they get, the fame, the power, the money, the, the honors and accolades that come with it. But what could be getting in the way of some people not exactly becoming a leader? So the first is that, do you really want to become one? Because nothing comes without a price. Are you willing for that sacrifice, commitment, and hard work? And am I fit to? In the sense that, do I really have the skill set, patience, and temperament to be a leader? It takes quite a bit from the leader. So, when somebody said KRP never gets angry, I mean, it's a great testimony to the fact that he is extremely tolerant and patient and very persuasive in his approach. So that's what makes it. Now, I just wanted to tell you that there is a huge amount of opportunity waiting for you people to become leaders. The question is, you have to decide which is your pick. So you have an area called research, for example. In fact, the best example was Rama. Education and teaching, I think Jayanti has been doing extremely well here, for instance. Clinical work, so many people, including EPAN, apart from research. And in organization, yes, certainly, I would say that from 2003 that I have known Tamil Nadu ISG, there has been a huge change, primarily led by KRP and the team that he creates, that included Bala as a very key factor. And social work, reforms, fixing ills of society, changing rules of the game, and agitational. So you can have your pick. This is the leadership spectrum and styles from Tamil Nadu. Dr. Madan Gopalan right on top. Dr. Mathan was one of the persons who I think did exceptionally well in stimulating and encouraging research in the country from CMC. I think a good bit of his team included Dr. Ralston, whom I had known. He moved off to Australia at the moment. I think Rama is carrying on the legacy. I can see Dr. Epan, who's doing a very good amount of research, managing a department, motivating people, and delivering very good clinical care. Jayanti has got a lot of people coming from all over the country to learn before their DM and DNB particularly. And we have got T.S. Chandrasekhan and V.G. Mohan Prasad, very good endoscopists, leaders, and now entrepreneurs. And entrepreneurial skills are also something which needs to be developed. And I think you people have done extremely well. And the team there, including Bala with KRP and Dr. Colonel Krishnan, you can see that was the story. And Dr. KRP, this is one Tamilian getting an award from another. Can you see that? So it's a big event in the history of Tamil Nadu, I would say. And I love both of them. And that was a very historic moment. So scopes and leadership in medicine, you have to pick. You can't be a leader for everything. For example, if you're good in organization, you may not be very good in research. And let's face it, like if your focus is on research, continue with that. That gives you enough scope. But one needs to define what one wants to do. And therefore you will, and if it comes as a passion, you will be able to do very well. Oh, I forgot L. Venkatakrishnan. He's also emerging as a very good leader and a teacher here in South. Now, this is a question which I'm sure some of you would ask, the very quiet types. Pirama, I'm sure, would ask, is it okay not to be a leader? I think Palni is usually distressed by Pirama's reluctance. Is it okay not to be a leader? Well, I guess so, in the sense that if you see that whole pack of wolves, everybody is not a leader. Maybe somebody else's time will come later on, but nevertheless, in recent memory, the person who struck me as an extraordinary person was Pope Benedict XVI, because he had his lifetime assured leadership of the papacy, and he's the first pope to have actually stepped down from being the leader of the papacy and passed it on to his next person. I mean, if you go through his details, he said clearly that he didn't feel up to it to remain the head of the papacy. It required courage. So initially people boo-booed him and all, but later on people said that he set a wonderful example that if you don't feel up to it, don't just occupy a chair, which I think was good. Coming back to the same old slide, remember that actually the chap in the right ahead is the person who is going to get exposed to most of the, the hunters coming from the other side and so on and so forth. Those who are in the middle are actually reasonably protected. I mean, they have enough space to run and all that. So comfort and peace can be more in the middle rungs rather than in the top rungs. But then how long will you be in the middle rung? At some point in time, the challenge of leadership will force you to come up. Last but not the least, Dr. Bala had his own style and way, and he leaves behind a legacy. For those of you who have interacted with him, he wasn't a very easy person. And the fact of the matter is that in spite of that, he was gutsy. He was pleasant but insistent, but he got his way. And I think that was a very good leadership quality that we had. So salutations to him. Thank you very much for this.
Professor Gordar Chaudhary. Kindly accept the scroll and this thing. Thank you very much.
I hope it was not too philosophical.
I don't think anyone else could have done so beautifully as GC Center. Director, GC Director.
Nice motivational talk.
we have the next session on Gastro Upskill Session 3. I request the following dignitaries to chair the session: Dr. V.G. Mohan Prasad, Dr. G. Loganathan, Dr. P. Basumani, Dr. S. Satyamurthy, and Dr. N.M. Alim. I request all the dignitaries to take the seat on the dais.
This is one. Sorry. No, that is on polypector. That's not the one. That's not the one. On the back. Yeah. This is the last one. Friends, good morning. It was a wonderful experience to be a part of this program for two reasons. One is beautifully organized. The second one is so beautifully attended. I understand that at some point of time they had to stop even the registrations because the hall size is less. So please give a big round of applause to the entire organizing team, Ravi, Chenduran, and the entire team Trichy for such a wonderful program. Scientifically, everybody was so thrilled and happy about the content, and that goes to, I think, Ubaldu and the entire team of Tamil Nadu SG. So we are going to the last session, that is before lunch, and this is the Gastro Upskill Session 3. May I request the moderator of this program, already Pirama is there. GC has been pointing to Pirama. He has to take up leadership now. So, and the panelists are Dr. Vinod Kumar, Dr. Madhura Prasad Suman, Dr. T.K. Anand, Dr. N.A. Rajesh, Dr. Papi Punithan, and Dr. N. Tirumurthy. So, we have a beautiful topic of panel on ERCP EUS interface. So, who else can be a better moderator than Pirama? So, he's a guru par excellence. He has trained all of us in EUS. So, we're really so happy to welcome the entire team and over to Pirama to mastermind the whole program.
Thank you, sir. Good afternoon to all. Again, I thank the organizing team for giving me this opportunity to moderate this session on EUS ERCP interface. And to take us through this panel discussion, I have 6 eminent panelists, all in very good interventional endoscopists who are here to help me take us through the discussion. So the next half an hour, we'll try and see, as the time permits, how we go through this interface. I was just interested to know what this interface meant, actually. It just says the place at which independent and often unrelated systems meet or communicate with each other. So where does EUS and ERCP actually communicate? Where is the interface? So we'll go through this in probably 3 broad outlines. We'll take some case scenarios and see how EUS and ERCP help each other out. So first thing will be about a diagnostic EUS and how it helps perform ERCP. The second session will be about when ERCP fails, does EUS bail us out? Where does it stand now? And what is the current role of the traditional PTBD when we have this EUS-related procedures, which are now taking more and more procedures being done? And also in pancreatic disorders, when you have an unsuccessful ERCP, where does EUS help in? To start off with, we'll go through simple case scenarios here. This is just a 35-year-old young lady who comes in with upper abdominal, typical biliary type of pain, lasting for about an hour, whose ultrasound shows multiple small gallstones and a dilated bile duct, about 11 millimeters, with abnormal LFTs, little cholangiohepatitic pattern. She was evaluated further with an MRCP, which shows CBD is dilated, but couldn't pick up any stones in the bile duct. So in this setting, I would ask to start with Tirumurthy. So what would be the next step? Should you go directly with the ERCP? Would you... Mics, please. Mics for the panelists. So do we go ahead directly with the ERCP, or should we wait, or what are your thoughts at this setting? So gallstones, typical biliary pain, has abnormal liver enzymes, but MRCP has not shown anything but ongoing pain.
CBD is dilated, but MRCP is not showing any calculi. That means the possibilities probably the gallbladder stone migrated CBD and passed out gallstone. That is the one possibility, because in that case scenario, enzymes will be high and still the CBD remains dilated. So still there is a possibility it is a passed out stone, or another possibility is maybe there is a small stone in the distal CBD which could have been missed in the MRCP.
So one option is possibly to wait and see, but other option is, do we still consider ERCP upfront, or would you?
No, in that with the availability of endo ultrasound, we may have to go for endo ultrasound, look for this thing, distal CBD any missed out stone, because sometimes MRCP can miss the stone. If it is there, distal CBD stone is there, then the same sitting we can do a ERCP.
So this lady did have a small cal in the lower CBD, which was possibly missed out on the MRCP. Actually, it was a stone which was on. When we did the procedure, we could see it move up and down. A small stone, probably it was in the lower CBD, which was missed up in the MRCP. So sometimes small, less than 5 millimeter calculi can be missed on an MRCP, but if your clinical suspicion is high and you have a dilated CBD or an abnormal liver enzymes, and if your clinical suspicion is high, probably we should still consider doing an EUS to rule out a stone procedure. But yes.
That clinical scenario, we could have done an ERCP even without an MRCP.
I'm coming to that. It all depends on whether you have in that given setting. Sometimes patients come to you with the reports. Then you have to take a call as to whether you want to do it or you leave it at that point in time. This is the same setting. Suppose the same lady comes to us with a history of pain, fever with chills for about 2 days, raised counts and abnormal liver enzymes with a bilirubin which is about 2, and ultrasound shows multiple gallstones but no biliary dilatation. Would you take up directly for an ERCP, or would you want to have a imaging prior to doing an ERCP?
This patient, she has presented with cholangitis with increased counts and increased ALP and with fever. In this setting, it's clearly, shows that patient is having probably a cholangitis-like picture. So we can directly, since the probability of common bile duct stones are high, we can directly take a ERCP for this patient.
Right. So coming to this, there are many guidelines which actually go through this, when to go directly for an ERCP and when to take a help of an imaging study. It could be MRCP or a EUS prior to taking a patient to an ERCP. Basically, if you have a very high risk for CBD stone, as has been alluded to, like if a patient presents with cholangitis.
Sorry,
yes, sir.
Can you allow public voting on this question?
Sure, please. With this second scenario, how would do we directly go for an ERCP?
How many say that we'll go for ERCP
in this
directly?
setting?
But still the ultrasound is not showing any dilated CBD.
Agreed. That is present. That is the reason why I put this case scenario.
So, how many feel another imaging modality like EUS is required beforehand? The house is divided.
Correct. So there is difference of opinion. Let's see what guidelines have to tell us. See, if there is a high risk for a CBD stone on the presentation, if the patient presents to you with cholangitis, irrespective of your ultrasound not showing a dilated CBD, has raised counts, bilirubin being 2.4, has fever with chills, we cannot exclude a cholangitis in such a patient. We have to go it is okay to proceed directly to ERCP, right? If again, if you find a CBD stone on ultrasound, it makes it easy. You are clear cut, there's high risk for CBD stones, so you go ahead with the ERCP. If there is an intermediate risk for CBD stone, that means abnormal liver tests or a dilated common bile duct, but you are not able to demonstrate a stone on the CBD in your ultrasound imaging, then you think of another modality like either EUS or an MRCP, as Dr. Ravi had asked, why go for an EUS or MRCP? No, but the patient sometimes, absolutely, that is why I want to make a point that MRCP may miss a stone. So it's just because your MRCP is normal, but if your clinical suspicion is high with abdominal pain, we can't rule out a CBD stone. Sometimes you do pick up small stones on EUS, so it has an additional value in picking up patients. I mean, that is not, that I agree with you, that's a practical problem, but that's a different thing.
Rama, can I add on?
Yes, please.
Suppose on an endosono, you didn't see any stone.
Yes.
Then what would have been your diagnosis? Or will you still go ahead with the ERCP?
The first case, I would have stopped. I wouldn't have proceeded with an ERCP.
So what would be your alternate diagnosis?
Might have been a passed off stone, I would have waited and watched out further off.
No, what
But
will
if
be your
I...
alternate diagnosis?
Meaning?
What will be your alternate diagnosis?
Possibly a passed off stone is what I would have thought of and well, but if there is anything else that you would like to add?
Wanted to add that
Okay.
EUS it has a very good negative predictive value for stones less than 2 millimeters, which MRCP less than 2 millimeter it may not detect. But if with a very good endosonologist, if there is no stone, then it's probably 100%.
That's what they are trying to come and tell us.
Yeah,
Yes, please. Sir.
Nice case scenario, and as you said very clearly, MRCP will miss, stone is less than 3 millimeter. Or one thing we should not forget is small stone is the ample of water.
Correct.
Which will not be picked up.
Picked up on an MRCP.
So whether he has come with the MRCP or not, I would like to do a side wing endoscopy, see the ampulla. If it is really bulging and prominent. Number two, I will do UES. In the same sitting, I will proceed with the ERCP. If nothing is there, I mean ampulla is very clear and there is a mouth opening of the papillary phase is little wide and no UES demonstrating stone, then I'll wait and watch and go ahead with the lab calling.
Sure.
I would like to add here one more point, Parama, if you would permit me. Like, if the CBD diameter is normal, as in this case, it runs a high risk for developing post-ERCP pancreatitis. The technique should be perfect. So it should be an expert to do an ERCP there. I would encourage further imaging as like what TSC said, either an MRCP or US, to make sure it is indicated. If it is a past stone, then there is no point. You know, you can just wait for 24 hours.
I mean,
So
that's
you
the
should be
question.
very careful.
If there is a cholangitis, and that is what I'm trying to pick up to, if there is a cholangitis and negative EUS, I mean, you don't have to probably even take up for another imaging. That is what at least the guidelines would want.
Agreed on, but the technique.
I agree. I absolutely agree with you. I'll just move on. I mean, we have some more interesting cases, some presentations which I would like to have some more discussions on. So case 2, I mean, here we have an elderly male who undergoes nowadays we have this routine master health checkup coming in. He's asymptomatic, undergoes a master health checkup, and that picks up a dilated bile duct. It's about 10 millimeters. There's no gallstones. LFT looks normal, but the physician who has asked for an MRCP, that again shows CBD, which is about 12 millimeters, no calculi, there's no mass seen in the bile duct, a smooth narrowing towards the lower bile duct. Dr. Anand, I mean, we'll take the panelists, and then I think I'll hold it for the audience also to come through.
I think if there are no alarm symptoms, I would not image him further. Maybe
What would be your thought
keep him
process
under
like?
keep him under follow. Chance of picking a CBD, distal CBD carcinoma or anything significant will be very low. So putting this patient to a EUS, I will have a lesser thing.
What would be the...
See,
the age of the patient is very important. The patient is asymptomatic, so depends upon the age, the dilatation of CBD will be there. If the age of the patient is less than 65, the diameter can be up to 8 millimeter. If the age of the patient is more than 65, 11 millimeter CBD is considered to be normal. But here in this patient, MRCP shows smooth narrowing of the distal CBD, maybe due to a previously passed out stone, we can consider. Also, we can go for a endo ultrasound for both the diagnosis as well as to get a diagnosis as well as do a biopsy also.
Okay. Rajesh,
No,
anything that you would
here,
want to...
see, we can divide these groups into whether the pre-test probability of diagnosing CBD pathology in US is present or not. If LFT is normal, we say the pre-test probability of US finding a pathology is very low. That too, to find a diagnosis with dismal prognosis, a carcinoma is said to be 0.5%. So you do 200 cases, you pick up one patient who has a carcinoma. So this has to be discussed with the patient, provided the sedation risk and invasive procedure and a suggestion for follow-up. If the patient willing for regular follow-up, we can go with regular follow-up because very unlikely we find a pathology with dismal prognosis in these patients.
Yes, sir.
Is the gallbladder distended or not?
I didn't know that. There's no, it's not, I mean, no gallstones, but I don't remember what it was. So suppose it's a distended gallbladder, sir?
And more likely due to obstruction, it's a non-distended gallbladder. You need to think of a primary CBD pathology.
That's what. So our main...
Even where whatever we have said as a stricture may not be a real stricture because
Correct.
it's a dilated CBD and you have a narrowed down lower
Normal
CBD,
lamp.
which may be interpreted as a
Stricture.
When you go on ERCP, it may not be so.
Exactly. So that is what, yes.
Still in this scenario, we have to think of again two possibilities. One is still the passed out stones. They'll have some kind of spasm and dilatation, that is one possibility. Second, the age is 68 years. Still we can go for a side wing scopy, small ampullary growth. Still it can be there, it will be released.
Periampullary diverticulum at this age can also cause some narrowing in the MRCP. So
Right.
Yes, possible.
So coming to that, I mean, just about someone, Madam had possibly told about the dilatation that we see. I mean, what we consider as normal size of bile ducts. Now, there's an interesting study which has come up just in the last episode edition of Gut. This is from a German Caucasian, basically Caucasian East German population, where they looked at population-based study where they did a follow-up MRCPs also. Here written interestingly, you will find that healthy people with their gallbladder in situ, the median CBD diameter was 5.3, but about 20% had a CBD which was more than 7 millimeters. PD also, we generally take about 3 millimeters in the head to be normal, but here see more than 3 millimeters, about 10% of normal healthy people who had dilated, what would have been called as a dilated CBD. If the cholecystectomy was done, then you would see that more than 60% had CBD more than 7 millimeters. These are normal people, asymptomatic people. So what I mean to say is that probably when you do cross-section such imagings in general population, what we think of as 4 millimeters or 6 millimeters as normal levels might be different. So what they have given us, the upper reference limits in that population, is that native patients in healthy, which is less than 65 years, just about 7 millimeters. If it is more than 65, up to 11 millimeters may be normal. So, I mean, this is some food for thought that we should think about. Because we are left with about 10 minutes, I think we'll go a little further because this is where the interface part comes through. So this just tells us that probably diagnostic US still has a role in picking up patients with the right indications for ERCP. I think that is what we are coming to. Coming to the next two case scenarios, which basically are malignant biliary obstruction. One, an elderly gentleman, typical presence with a progressive painless jaundice, has a high bilirubin, has palpable gallbladder. On imaging, is noted to have a mass in the head of pancreas, which is locally advanced, invading into the splenoportal confluence with mild ascites. This proceeds with done an EUS with a biopsy, but deep cannulation of the bile duct was not possible. This is one case scenario. On the other hand, another patient who has again a progressive jaundice has a obstruction which is in the mid-CBD with a gallbladder malignancy, which is also infiltrating into the duodenum. So a scope could not go up into the D2. So given these two scenarios, I would request the panelists, probably Dr. Rajesh, to tell us how he would proceed with this. When one, where your ERCP deep cannulation of bile duct is...
Yeah, the first case, the papilla is accessible.
Right.
There is dilatation till the distal end. So in these patients,
conventionally, what would have been our option?
Conventionally, it would have been ERCP through the transpapillary route, but that failed in this patient.
Yeah.
So in these patients, I think an extrahepatic biliary access route with EUS is a definite possibility, especially an access from the D1, and we can go ahead with lumen opposing metallic stent placement in the first case where there was dilatation till the distal end. In the second case, however, there was D2 narrowing and there was obstruction more proximally. In these patients, a transmural approach through the transgastric route and US HGS is a good approach in these patients, and either antegrade stenting or transmural stenting can be done.
Dr. What are the different options actually? For sake of postgraduates, if you were to tell us broadly, if you were to
say broadly, in patients in whom conventional ERCP is not possible, US guided biliary access can be done, and broadly we can divide these into intrahepatic approach or extrahepatic approach. Intrahepatic approach basically involves functioning through the liver and accessing the intrahepatic biliary radicals. In these cases, the prerequisite should be a dilated intrahepatic biliary radical at least 5 millimeters, and the distance between the liver tissue and your duct should be less than 3 centimeters. So this is an ideal scenario, and preferably segment 2 or segment 3 duct should be targeted in these patients. And in intrahepatic route, we can either do transmural drainage or we can do antegrade stenting, where we can, if we can pass through the stricture, we can do antegrade stenting. That is another option. Or we can even try rendezvous, where the guide wire can be passed across the CBD into the lumen if ampulla is accessible.
Correct. So it basically will come down to whether you have an accessible ampulla,
or
if you have a duodenal obstruction, then your approach differs.
Yes.
And one thing is, it can be in rendezvous where you have a guide wire which assists us to complete the ERCP subsequently,
Correct,
or you do a transcentric stenting. So what factors will determine which one to choose, Doctor? One is, of course, accessibility of papilla. The other one would be about the dilatation of the bile ducts, the intrahepatic bile duct. So going through that, if your intrahepatic bile duct is not dilated, then what option do we have in that such setting?
If intrahepatic bile duct is, if it's dilated only, we can use the intrahepatic approach. So when it's not dilated, we will try to go through a CDS approach, or we'll try a rendezvous rather than go through a hepaticogastrostomy.
So when we are in periphery where US is not available, in this situation, we can try one more time, or some other person with some specialized instruments.
Absolutely.
That also work.
Absolutely. I agree with you. Anything?
So one more thing is, we have to be always, when you are difficult papilla to access, you're not able to do ERCP, we are planning for US guided biliary intervention, always first we have to see the patient is operable or not. If it is operable, always discuss with the surgeon. Because when we are doing a US guided biliary drainage, either choledochoduodenostomy or hepatic gastrostomy, it's always we have to have the point with the surgeon. Because after the surgery, if it is operable, after the surgery, the anastomosis, we have to discuss with the surgeon and we have to take a decision.
I'd just like to comment on that, sir.
Yes.
So when we are doing some US guided biliary drainage, initially we plan it because patient is inoperable, but some complication occurs, suddenly the inoperable patients become operable.
Not really operable, you have to send them across to a surgery, which becomes much more difficult to manage.
Pirama,
Yes,
it's I know it's an US discussion, so one should be aware. Traditionally, we have been always doing
PTBD.
these cases through PTBD.
I'm coming
it
to that
depends
also.
on our strength and the institution's strength.
Correct. I'm just coming to that as well, just for things. So, Dr. Thinks can we take us through, for the benefit of postgraduates, what are the steps of this EUS guided drainage procedure? So, anyone can take it through. So, basically, there are 4 steps that we look at.
So for ES guided biliary drainage, if we are going to go through an intrahepatic route, as doctor was telling, we need to have a 1 to 3 centimeter of liver parenchyma to transverse, and we choose segment 3 if possible, less so segment 2, because we don't want it to go through the esophagus and mediastinum. So if segment, and also we should plan the route because it's very difficult to maneuver the stiff
Accessories.
needle, and the guide wire, too much of manipulation will strip the guide wire. So we should plan the angle and the route which we are taking. Are we doing it for the sake of rendezvous, or are we actually going to do a antegrade or hepaticogastrostomy stent placement? So that angle should be pre-planned, and the tract dilators also should be pre-planned based
Right.
on the...
So, can we tell us about the clinical, what are the success rates with this kind of advanced EUS biliary drainage, and what are the worrisome features? What are the complications that we should be looking out for?
So these are the 4 options available. I'll add one more thing. I mean, US-guided cholecystogastrostomy is also an option available where the cystic duct is patent.
Right.
So that's more easier, just puncture with artexios, you can connect to the stomach. So out of these 4, US-guided choledochordiotomy, so almost the success rates are good except for this antegrade stenting according to the studies. But what I feel is this HGS, hepaticogastrostomy, has more complications than other things. There's rate of stent migrations, bile leak, it's more with peritonitis, it's more with hepaticogastrostomy. So all these are good options, but except, I'm not a firm favorite for this HGS.
Okay. And the complication rates?
So the complication includes bile leakage, bleeding, perforation, stent migration, and pancreatitis. Out of this, I think CDS bile leak is 2.8, almost same
more or less
with all
same,
these procedures.
What is important is that if you look at the cumulative adverse events, they are all in 2 digits, still about 10-20%. So just much higher than the conventional ERCP that we come through.
There are papers coming up. We are discussing all this US guided biliary drainage as an alternative option, but there are papers coming up where we can do on primary US guided biliary drainage than on primary ERCP.
So primary US drainage with ERCP. So there have been more studies on that. So, yeah.
So with the risk of complications, although the technical success rates seem that adverse events like pancreatitis are low with this US guided biliary drainage than with ERCPs.
Correct. So even though its technical success is still as much as good as the ERCP, I think what is worrisome, what is the Achilles heel still here is that the adverse events rates, even in the best of centers where they did this randomized control trials with experienced endoscopists, is to the tune of 10-15%. Now, as Dr. Ravi had pointed out, what about EUSBD versus PTBD as a rescue when you have a failed ERCP? Rajesh.
See, though earlier the PTBD was the first modality in patients with inaccessible, when ERCP fails, but it has been gradually replaced by US biliary drainage because the complication rates, though the technical success of both are similar, the complication rates with PTBD is higher at 35%, whereas the cumulative complication with USBD is only around 15-20%. There are repeated reinterventions in risk of catheter migration, infection, biliary peritonitis, and repeated reinterventions needed in patients with PTBD, and patient has to have an external bag.
Finally,
but these things can be overcome with...
but it also depends on how good our endoscopy skill is as well as our confidence on the intervention endoscopist.
We should compare the best intervention radiologists with the best US therapists whenever we are comparing 2 modalities.
Right. So we'll skip this pancreatic procedures, but what I will finish off with this is these are high-end interventional procedures. So what we also need to bring into both in this forum is that, the need for such advanced procedures in a good skilled endoscopy unit is going to be possibly in single digits. Like in this study from Dr. Shyam's unit says that the need for any US-guided biliary drainage in a failed ERCP is going to, in their setting was 0.6, probably in another setting probably it will just be about in 5%, probably not more than that. And interestingly, there was a study from the Spanish group where they did initial experience in the community-based hospitals when they tried doing this US-guided biliary drainage. The success rates were only in 60%. And the complication rates were about 20-25%. So what it means is that we need to have good training and we need to have very skilled endoscopists to do this. And the learning curve can be pretty stiff. And one on the left shows us what is the average learning curve for US-guided biliary drainage, and you will find that the median procedural time is close to an hour. So when you do a failed ERCP where you have already spent 30 minutes, 40 minutes trying to cannulate and you're not able to, then you must be mentally prepared for doing a procedure for another hour for an US-guided biliary drainage procedure, and you can't be rushing it out, and you find that it takes at least 30 procedures for us to get, even the skilled endoscopists to get enough confidence to do it within that time. Or on the other hand, if you have a pancreatic duct intervention, it's going to be even longer. So it takes a more learning curve with, even for trained endoscopists. So I think time is just running out. So we'll summarize here. We have looked at how EUS, I think a diagnostic EUS helps choose the patients, right patients for your intervention. And EUS-guided biliary drainage procedures are used as a rescue for failed DRCP. There is more and more literature which are emerging where they use primary EUS-guided biliary drainage for distant malignant biliary obstruction. We have looked at the options of EUS-guided biliary drainage, how to choose them, what conditions will determine, and we have skipped the pancreatic duct. But what I want to, for the postgraduates to know is that these are very good procedures you look at, but these are highly skilled ones which you need good training. They are needed in a very few number of people, and there is still a high risk of complications. And if there is anything else from the organizers? Thank you all. I thank all the panelists.
Pirama should be appreciated. It's only one thing. I want to appreciate you for a very honest opinion about biliary interventions, EUS guided.
Thank you all. Sir? Thank you.
Thank you, Prama. Thank you all the panelists. On behalf of the chairpersons, I thank for a wonderful discussion and finishing in time.
Thank you, sir.
Thank you, sir. Thank you all. Moving on to the final session, we have PG Session 4, quiz by Dr. A.C. Arun.
Good afternoon, one and all. Welcome to the final session of this TNISG. And this is the quiz program for the postgraduate students. The students showed lots of enthusiasm by registering for the quiz. Almost 13 teams registered for the quiz. So we held a initial screening first round. It was a written round, and we have selected 5 teams out of the 13 teams for the final session. So now I am going to announce the first 5 teams. They are not in the order of merit. They are in the alphabetical order for the institutes. The first team is from Apollo Hospitals, Chennai, Dr. Priyansh Bhavani and Dr. Amara Sadguna Rao. Please come to the stage. The second team from Global Health City, Chennai, Dr. Dinu Abhirami and Dr. Arvind. Please come to the stage. Third team from Jipmar Pondicherry, Dr. Muhammad Bilal Azam and Dr. Sandeep Kumar Prajapati. Fourth team from Madurai Medical College, Dr. S. Vinod and Dr. Kondala Rao Edupati. Fifth team from Tirunelveli Medical College, Dr. R. Kishore Kumar and Dr. U. Ramakrishnan. Team A, please occupy these 2 chairs, please. A, B, C, D, E. A is Apollo Chennai, B is Global Health City, C is Jipmar, D is Madurai Medical College, and E is Tirunelveli Medical College. And I invite Dr. Rabindranath to help me in the quiz. So these are the rules for the final rounds. So each team will get 5 direct questions alternatively, and the correct answer will carry 20 marks. There is no negative marks in the direct questions. If the first team does not answer the question correctly, the question will go to the other 4 teams, and they will be provided with a buzzer. So one who presses the buzzer first will get the chance to answer. I request the audio-visual team to give the buzzers fast. And for the direct questions, the team will get 10 seconds to answer. If they are not answering within the first 10 seconds, it will go to the buzzer. And after pressing the buzzer, if you answer correctly, you will get 15 marks. But the wrong answer will bring you again minus 10 marks. To avoid pressing the buzzer unnecessarily, we have kept this negative marks. And this is a disclaimer. So audio visual team ready? I have taken few questions from the sessions that has happened over the last 2 days, so you can brush up your things. If you have attended diligently, it will be easier for you to answer. And just remember the negative marks in the buzzer. If you press the buzzer and don't answer also, you will get negative marks, 10 marks. Check. I request the A team to check their buzzer. Okay. Half tilt. C team. D. Team E. Team E. Press the button. Okay, it's all set. The teams, are you ready? You can take the mics, yes. So we'll go to the questions. The first question goes to Team A. Team E, are you ready? Yeah. So in Babino 7, for cirrhosis, recompensation, not decompensation, recompensation, which is incorrect. In HBV cirrhosis, sustained virological response is a criteria. Resolution of ascites of diuretics is a criteria. Beta blockers can be stopped once recompensation occurs. In absence of variceal bleed occurs for 12 months is a criteria. Your time starts now.
One, sir. In HBV cirrhosis, sustained viral suppression is a criteria.
So wrong answer. So now, okay, the buzzer should be pressed once I say buzzer time. Okay, now the question goes to the other 4 teams. It's buzzer time. Okay, D.
Beta blocker can be stopped once recompensation occurs.
Okay, that's the correct answer. Can you explain? Can you explain?
Is in the criteria
From the anyone from the audience want to contribute? Only PGs. So it can be stopped only when the clinically significant portal hypertension also resolves. So not just recompensation criteria is fulfilled. So that's the reason. So the mark goes to Team D. Okay. So Team B, are you ready? He is a 75 years male having obstructive jaundice with a bilirubin of 28 due to a periampullary tumor. And he was planned for ERCP, but it could not be done because guide wire could not pass through the periampullary tumor into CBD. So what is the next best option? Whether it's an EUS guided hepaticogastrostomy, EUS rendered biliary drainage, surgical segment 5 bypass, or surgical segment 3 bypass. Your time starts now.
2, sir. EUS roundhouse biliary drainage.
Can you be louder?
2, sir. EUS roundhouse.
Okay, correct answer. Why not option 1?
So hepaticogastrostomy will drain only the left or the right lobe.
So that's not, it's usually done for hilar tumors. So the best preferred way is the rendezvous procedure. So full marks for team B. Team C, a 50-year male with cirrhosis who has been listed for and is waiting for liver transplantation, and he is having a small tumor, T1 stage or BCLC, very early stage hepatocellular carcinoma. So what should be done next? Radiofrequency ablation of the tumor, TACE, observation with follow-up imaging, anatomical resection of the tumor. Your time starts now.
4. Anatomical resection of the tumor.
Wrong answer. So it's buzzer time. Team B. Yes.
Observation, follow-up imaging.
Can you be louder?
C, sir. Observation, follow-up imaging.
Okay. Though you are hesitant, the answer is correct. So it's observation with follow-up imaging. Because it comes, the transplant itself is the treatment modality for early stage. So you can safely wait with follow-up imaging. So that's the correct answer. So team B gets extra points. So team D, he is a 79-year-old male evaluated for epigastric pain and loss of appetite. An endoscopy showed a submucosal lesion in the antrum. EUS showed a 4 into 6 centimeter mass in the stomach arising from the second layer, mucosa and lamina propria. So based upon the EUS appearance alone, which tumor is most likely? Whether it's a carcinoid, GIST, lipoma, duplication cyst. Your time starts now.
GIST, sir. Second option.
Wrong. So it's buzzer time. C. So team C, what's your answer?
Carcinoid tumor. Carcinoid tumor.
Okay, again correct answer. How? Can you explain?
Usually carcinoid tumor arises from that, and usually this is the only submucosal lesion wherein mucosal biopsies, if you take it bite on bite, you can get.
So we have run it in the other way. Okay, good. So usually based upon the layers, carcinoid usually second layer, lipoma third layer, pancreatic cyst and GIST from fourth layers. So that's it. So team C gets the extra points. Team 5, team E, is a 23-year male referred from screening during visa process for raised bilirubin. His LFT showed bilirubin of 3 with indirect component more. SGOT, SGPT, ALP were all normal. There was mild anemia. Ultrasound showed moderate splenomegaly with normal liver. He is totally asymptomatic with normal liver. His most probable diagnosis is Dubin-Johnson syndrome, thalassemia minor, Gilbert syndrome, Crigler-Najjar syndrome 1. Your time starts now.
Thalassemia minor.
What?
Thalassemia minor.
Okay, good. It's the correct answer. So the clue is mild anemia and splenomegaly. Though it's a normal liver and every parameters are normal, so because of the splenomegaly and anemia, we go for thalassemia minor. So full marks. So second round starts. Team A, the gene mutation which is studied prior to starting azathioprine is NOD2, TMPT, NUDT15, ATG16L1. Your time starts now.
3 NUDT15, sir.
Good, good. So it was a optical illusion in the option 2. It is actually TMPT. It's not TPMT, it's not TMPT. So that was the spoiler, but they got it correctly, so full marks. Okay, sir. Yeah. So it is NUDT 15 is the right answer for this 6th question. So team B, the liquid biopsy used in cholangiocarcinoma detects what? Extracellular vesicles EV, circulating tumor cells, gene mutations, RNA or DNA. So your time starts now.
2, sir. Circulating tumor cells.
Very good. That's the correct answer. Circulating tumor cells is the right answer. Full marks. So next question for team C. The most rapidly progressing cirrhosis is cirrhosis in autoimmune hepatitis type 2, Indian childhood cirrhosis, Budd-Chiari, secondary biliary cirrhosis. Your time starts now.
Secondary biliary cirrhosis.
Good. So that's the correct answer. Secondary biliary cirrhosis. Team D. Lonafarnib is related to what? GIST, hepatitis D, hepatitis C, hepatocellular carcinoma.
Second option, sir, hepatitis D.
Good. So what group of drug is that? Okay, anyway, full marks. It's a frenylation inhibitors. It's a new class of antiviral drugs which is being tried. Team E. The waterfall study is related to what? Biologicals in IBD, refractory ascites in cirrhosis, DA in hepatitis C, fluid management in acute pancreatitis.
Fluid management acute pancreatitis.
Very good. So can you tell what was the result?
So moderate difference between volume in moderate to should not follow aggressive fluid resuscitation in acute pancreatitis.
So what will happen?
Okay, pulmonary edema.
Yeah, fluid overload. So that was the conclusion. Good, very good. So we are coming to the end of round 2. I request Dr. Abhinanath to tell the scores at the end of round 2.
The team B is leading with 50 points. Team E is second with 40 points. Team C and D with 35 points. And team A scored 20 points.
So there is a neck-to-neck competition in the first 4 teams. So let's see what happens in the next round. So it's a visual treat. Team A, are you ready? Okay. Identify this personality. There's no option for this. Wait. So for these innocent souls, this is Pamela Anderson. But the question is, what is her gastropathology? What is her gastro illness? Time starts now. No prompting from the audience. Okay. So it's buzzer time. Team C.
Hepatitis C.
Excellent. So hepatitis C. So she was among one of the first few people to get the sofosbuvir, and she attained SVR. So team B, are you ready? So it's an endoscopy spotter. Your time starts now.
Gave gastric and transvascular atresia.
No. So it's buzzer time. Okay. Nobody wants to take? Any other postgraduates? Audience? Good. But there is a name for it. It's iron deposition, but it's a name for it. No? You are close. Pseudomelanosis. So melanosis is whenever you get melanin deposition. So this is iron, or sometimes sulfur containing diuretics long-term intake can lead to this. This is pseudomelanosis. Okay. So nobody gets the points. Team C, are you ready? So what is this? What is the diagnosis?
IPMN.
Good, very good. So fish mouth appearance which occurs in IPMN, full marks. Team D identifies this famous gastroenterologist.
Peter Cotton.
Very good. Full marks. So team E. So this is a duodenal biopsy of a patient with small bowel diarrhea. The clue is look where you don't look. Okay, time is over. Okay, team D. Yeah. Very good. So giardiasis. You have to look into in the lumen, not actually in the villus. You have to look into the lumen to see look for the giardiasis. So next, team A. What's the name of this procedure or graph or investigation? Your time starts now.
A TEG, sir.
You have to tell.
Thromboelastogram.
Good, very good. What is the usage? Okay, so know the exact what's the coagulation status of the patient used commonly in liver transplantation. So it's thromboelastography, TEG. Very good. Team B. All are genes linked with NAFLD except NOD2, PNPLA3, GCKR, MBOT7. Your time starts now.
Three, sir. GCKR.
No. So it's buzzer time. Team C.
NOD2.
Good. So what is NOD2 related to?
IBD.
Yeah, it's Crohn's disease predominantly. So if you know that it's NOD2 is related to Crohn's, it would have been easier. Okay. So next question for team C. A 56-year-old man was diagnosed 8 years back with short segment non-dysplastic Barrett. Look carefully, short segment non-dysplastic Barrett. So what's the chance of developing esophageal carcinoma per year? The options are 0.1 to 0.3, 0.5 to 1, 1 to 2, 4 to 5. Your time starts now.
That 0.5 to 1%.
Wrong. So buzzer time. Team E.
0.1 to 0.3.
Good. So 0.1 to 0.3 percentage. Good. So team D. The current role of ribavirin in hepatitis C treatment is what? Additive drug for HIV, HCV co-infection, additive drug for HCV decompensated cirrhosis, additive drug for acute HCV infection. No role for ribavirin currently. Your time starts.
Sir, second option, additive drug for HCV decompensated.
Very good. So it's additive drug for HCV decompensated cirrhosis. Team E. A 65-year-old woman who have been doing well for 10 years after Heller's myotomy for achalasia. Now she presents with recurrent dysphagia and weight loss. And barium swallow shows a dilated esophagus, hugely dilated, 12 centimeters with a sigmoid configuration. So what is the best treatment option? Pneumatic dilatation, repeat Heller's myotomy, POEM, esophagectomy. Your time starts now.
Pneumatic dilatation.
Wrong. So it's going for buzzer. Team C. Good.
Esophagectomy.
So can you explain why?
Sir, sigmoid esophagus is there, it is already decompensated esophagus. So no role of any other procedures other than esophagectomy.
Cannot say there is no role, but right now the answer is esophagectomy. That's the correct answer for the time being. There are procedures like two-stage POEM that is coming up. It may take up in the near future, but right for the time being it is esophagectomy. When there is a sigmoid esophagus which is hugely dilated, more than 10 centimeters, at most 12 centimeters, the answer is esophagectomy. So correct answer. So at the end of fourth round, there is only one more round now. So at the end of fourth round, let's check the marks.
Now the team from Jipmer, Team C is leading with 100 points. And Team D from Madurai, 90 points. In Tirunelveli, Team E, 55 points. And Team B, 50. And Team A, 40.
Team C and D has been taking some risks, and that is giving some the results. So coming to the final round for Team A, final question for Team A. So which of these clinical scenarios qualifies for a MELD exception in liver transplant? A patient with chronic HCV with 2 lesions, size 3.3 and 1.6. A patient with portopulmonary hypertension with mean pulmonary artery pressure 45 on treatment. A patient with HPS and PO2 65 on room air. A patient with primary hyperoxaluria and end-stage renal disease requiring dialysis. Your time starts now.
Two, sir. A patient with POPH and MPAP of 45.
Wrong answer. So the buzzer time. So Team B.
4, sir. A patient with primary hyperoxaluria.
Yes, that's the right answer. With primary hyperoxaluria with end-stage renal disease. So they get the extra points. So final direct question for Team B. The Paris criteria for autoimmune hepatitis PBC overlap includes all except GGT more than 5 times, ALT more than 5 times, liver biopsy showing cholestasis, and serum IgG more than 2 times. Your time starts now.
C, sir. Liver biopsy including showing cholestasis.
That's the right answer. Can you explain why you chose this?
Features, sir.
So you know all the other options are correct, right? So liver biopsy showing cholestasis alone is not enough. There should be florid bile duct lesions should be there to call it as for the exact criteria. So full marks for them. So Team C, final straight question. A 65 years male who is on dual antiplatelets for coronary stenting 6 months back. Now he presents with cholangitis with a bilirubin 8. MRCP shows a single large CBD stone, 1.5 centimeter with obstruction. So what's the next best step? So best step, so you should be imagining that you have all the equipments with you and what is best for the patient also. Extracorporeal shock wave lithotripsy, higher antibiotic coverage with double pseudomonas cover, ERCP plus plastic stent placement, limited cholangioscopy and stone removal. Your time starts now.
3. ERCP plus stent placement.
Okay, very good. So final question for Team D. Again in Bavino 7 guidelines 2022, LSM in fibroscan by transient elastography, what is true or what is false actually? The question is what is false? Less than 7 kilopascal rules out compensated advanced chronic liver disease, C, ACLD. Rule of 5, 10, 15, 20, 25 should be used to denote progressively higher relative risk of decompensation. LSM by transient elastography less than 15 plus platelet less than 1.5 rules out clinically significant portal hypertension. Values less than 15 are highly suggestive of CACLD. Your time starts now.
Which is true or false, sir?
Which is false. So time up?
Second option is
No. Time up? So buzzer time. Team B.
2, sir. A rule of 5 for LSM by transient elastography.
Wrong answer. So any audience want to contribute? No, it's first option. Less than 10 kilopascal rules out compensated advanced chronic liver disease, not 7. So that's the trick. So final question for the final team.
I have some problem with the buzzer.
Okay, please check. Now we can check once. Yeah. No. So only when I tell it's buzzer time, it will be activated. Otherwise, I will be deactivating it. So final question regarding IPSID. immunoproliferative small intestinal disease, all are true except. Occurs usually in second and third decades. A type of B-cell lymphoma usually has good prognosis, usually occurs in proximal small intestine. The time starts.
Sir, two a type of B-cell lymphoma.
Wrong answer. So it's buzzer time. Team C. Yes.
D, except usually occurs in proximal small intestine. All are true except. So D is wrong.
No, wrong answer. So what is the correct answer from the audience? Yes, sir. So it has a very poor prognosis usually. Whatever cases I have seen, all of them expired even during my residency itself. So that was the situation. So it has a very poor prognosis. So we come to the conclusion of the end of the sessions. I request Dr. Rabindranath to announce the results. Sir, will we announce the results now or at the end of the sessions? No. Okay. Your names.
The third place goes to Trinelveli Medical College.
Dr. Kishore Kumar and Dr. U. Ramakrishnan. Congrats.
Second place go to Madurai Medical College.
Dr. S. Vinod and Dr. Kondalarao Edupati.
The first place goes to JIPMER.
So big round of applause for them. Dr. Mohammad Bilal Assam and Sandeep Kumar Prajapati. Thank you one and all.
So we are coming to the end of our annual meetings. So I request the organizing secretary, Dr. Ravi and Dr. Chandran, to come on the dais. Because there are a lot of prizes, I request all the... Sir, come over the dais. Please give a huge round of applause for this. I request our patron to come on the dais. Professor Jayanti. Dr. Gordas Chowdhury. Dr. Raghuram. Dr. T.S. Chandrasekhar. Dr. L. Venkatakrishnan. Dr. Epan. Dr. Piramanayagam. A huge round of applause for Piramanayagam because he is going to take over, and I know this is a huge responsibility, and we know that Pirama is one of the busiest consultant in Apollo. Almost she sleeps at Apollo entire day, and I know this is going to be a huge responsibility, but as a TNIG, I think it is a strong society, and all work together, and we all support you, and we'll take it further heights. So coming to the awards, I think this is a Rising Star Award. Dr. Arul Prakash, please. Our treasurer, new treasurer. Yeah, very important, because without this signature, we cannot give prizes. So TNAG Rising Star Award, we started last year. I think there is a close neck-and-neck competition for this year. The judges felt very difficulty. The award goes to Dr. P.L. Alagaman. I request Professor Jayanti to hand over the award to trophy and. The ISGTN award for the DM Top Prize Award goes to Dr. U.S. Umashankar. I request Professor Raghuram to give the award. So we started awards for the best publication of Professor Mathan Awards. The first prize goes to Arul Raj Ramakrishnan. I request Professor Gordas Chowdhury to give the award. The second prize goes to Dr. Veera Ravan. I don't know, Veera Ravan is not here. If anybody from Tirumurti is there, please. Tirumurti will get on behalf of Veera Ravan. I request Professor T.S. Cancer Institute. Cancer Institute. Professor T.S. will give the award. There are two third prizes, joint prizes, and I request Kedari Shetty or anybody from Global, please come over on the dais. And Joy, anybody, any PGs from Global? Yeah, please. Professor L. Venkatakrishnan will give the award. And the joint second prize will be Dr. N.A. Rajesh. Anybody from SRM, Rajesh? Professor Ratnaswamy is there. So the first prize for the endoscopy video, again a stiff competition, and almost all the top 3 has close prize. So I request Dr. TSC to give the award to the Dr. Arul. The second prize goes to Dr. Vishnu Abhishek. I request Dr. KRP to give the award. The third prize goes to Dr. Gokul. Satyamati will receive the award. I request Dr. Ravi to give the award. And the e-poster category awards, in the luminal category, the first prize goes to Dr. Vijay from CMC Valley. Anybody from CMC, please? I request Dr. Paramanayam to give the award. The second prize goes to Dr. Amal Wells from Kilpauk Medical College. Dr. Epan will give the award. The third prize is Dr. Surabhi from Coimbatore Medical College. I request Chanduran to give the award to. The first prize under the liver category goes to Dr. Mohammad Bilal Azam from Jipmer, Pondicherry. I request Dr. Gurdas Chowdhury to give the award. The second prize goes to Dr. Leenath from CMC Vellore. I request Professor Jayanti to give the award. The third prize goes to Dr. Sita Badola from MMC. Anybody from MMC? Prem is not there. Under the best case reports category, the first prize goes to Dr. Kishore Kumar from Tirunelveli Medical College. I request Dr. Epan to give the award. Second prize, Dr. Ashisha Janila from CMC Valley. I request Arul Prakash to give the award to. Third prize goes to Dr. Nishal Modak of KMC Chennai. I request Dr. Chanduran to give the award. In the plenary session, the first prize goes to Dr. Dhanush Thomas of PSG Coimbatore. I request Dr. Gurdas Chowdhury to give the award to. The second prize goes to Dr. Krishna Bharadwaj of CMC Valley. I request Dr. KRP to give the award. There is a 2 joint third prizes. I request Dr. Janavi Sridhar from SRMC Chennai. I request Professor Gordas Chowdhury to give the award. She is a third year MBBS student, not yet. The joint third prize goes to Dr. Raghavendra Ashok Nabi, SM Stanley Medical College, Chennai. I request Dr. LVK to give the award. So the quiz winners, please come. The first prize, I think the Jipmer Medical College, please come on the dais. I request Dr. Ravi to give the award. The second prize goes to Madurai Medical College. I request Dr. Paramanayam to give the award. The third prize goes to Tirunelveli Medical College. I request Dr. Chenduran to give the award. Before that, there is a memento from the pharma to the organizing secretary, Dr. Rabi, will be receiving the award from Dr. Gurdas Chowdhury. Dr. L. Venkatakrishnan will receive the award from Dr. TSC. So one who has found this TNAG to go stronger, we give an award to our patron, Dr. Palniswamy. I request Dr. Gordas to give the award to patron. And we call upon our President-elect Prem to receive the award because he is the one who has, next to KRP, I think he is the one who spent maximum time for the society. Since we don't have Dr. Bala, he almost replaces Bala. We request Dr. Prem. I request Dr. Raghuram to give. There is one award for myself and I'll take it.
I would like to congratulate Dr. Ubal for having taken the society to greater heights after he took over as secretary 4 years back. And now I think a lot of new innovations, initiations And now I think Dr. Gurdas Chaudhary will agree, and this is one of the best chapters in India, and it has taken to such levels. Thank you, Dr. Upal. Wonderful. I would like Gurdas.
Big congratulations to Upal. I think that his period was a difficult one. COVID came in between. Am I right? And then it started off in between. There was the difficult phase. His communications were fantastic. And number two, you see always he's smiling, which is very important for a secretary. Excellent. He did extremely well.
As the president of ESG, I visited so many state chapters. I can easily tell you Tamil Nadu is the best. The reason behind, apart from our patron supporting, we have very good teamwork. The most dynamic person has to be the secretary. And his personal attributes and character in such a way, he never gets tensed up. He is very cool. Most importantly, he listens to everybody's suggestion. Then he will make his own decision. And that is different, but he's very innovative. And he knows how to wrap up with everybody. And only stress I've seen him is growing beard only. That. Otherwise, absolutely flawless program. He has done it. And despite he is a very good endoscopist, clinician in the Apollo Hospital, how he spends time and coordinating with this communication and timely presence of mind. He knows how to project the society ahead of the others. And you should not forget the contribution by his daughter for the logos, all the things, whatever. A leader is the one who shows the way, paves the way, and he achieves it. And is a standing example. We are very delighted and fortunate to have him had as our secretary for the Tamil Nadu ISG. And we look forward more from him as a team. Thank you.
When Indian Society of Gastroenterologists was fighting, almost getting in a disintegrated post, Professor Mathan, Professor Madangopalan and Rangabhashyam took over the reins and they united everybody. Even though they're short-temperedness, they united. But Upal has taken the TNISG in a smiling mood without any problems. Good luck for future references.
There are few more prizes. One is from the Gutford Pharma. They have conducted some games, and it is happy to know that Dr. Prem Kumar, our president-elect, got the first prize. I requested Professor Gurdas Chaudhary to give the
Take picture.
Targets.
இருக்காங்களா கையில் கொடுத்துருக்கீங்களா ஓகே The second, other three prizes are Dr. Sriram Madurai, Dr. Sadasivam Karur, and Dr. Manigandan Karur. And the organizing team also wants to thank the faculty who came on 24th for the workshop. We request Dr. Vadivel Kumaran to come on the dais. Dr. Radha, Dr. Ravi, Dr. Sridhar, Dr. Tirumurthy. Vishnu. Ravi Sarchandran, anything wants to thank? No. So, thank you everyone. We will meet again every month and next midterm and next year. Thank you. Please join us for lunch.
Excellent.
Tomorrow morning. How are you? Yeah, I'll be going. What did you go? I'll be going just to the sites. No, that's okay. But I think Palni wants to take us somewhere else also. So, good, all the best.